Welcome to the first Growth Hormone Deficiency Education Conference. I'm Dr. Vivian Chin, and joining me today is Dr. Robert Rappaport, Dr. Vacharapan Umpaichitra, Dr. Renee Bargman, and Dr. Elka Jacobson-Dickman. I will be moderating the meeting today and will field your questions and comments through the Zoom chat, or you can also raise your hand. This is a conference that we created for a wide audience from pediatric practitioners such as students, trainees, to general pediatricians and endocrinologists. And I know today we have an international audience as well as local people, so welcome everyone. It might be evening, so good evening and good afternoon as well. So today we'll talk about the clinical approach to short stature, along with very interesting interactive cases. And also we'll cover FDA indications for growth hormone therapies. And also we'll be covering new and emerging long-acting growth hormone therapies and their efficacy, safety, and potential clinical applicability. Before we started the conference, we asked participants to complete a survey, and after this conference, we'll assess everyone's responses as well. I wanted to go over very quickly how most people answered. So question one, everyone mostly answered 2.3rd percentile and below as a definition of short stature. There are some people who use the definition of 1st percentile and others use 5th percentile. Okay, in terms of which is not included in a diagnostic workup for short stature, most people answered random growth hormone. Some others answered lipid panel and A1C. I'm not going to tell you what the correct answer is, but question 3, which is not part of the differential for short stature, most people answered obesity. Some of you answered precocious puberty. Question 4, which of the following cases does not require evaluation for growth? Most of you answered a 5-year-old prepubertal boy with a growth velocity of 5 centimeters a year. Question 5, what are the FDA approved indications for growth hormone? Most of you answered all of the above. Some of you selected number 1, growth hormone deficiency, and various questions answers. Number 6, what is the correlation between adherence and efficacy of growth hormone treatment? Most of you answered suboptimal adherence negatively affects growth response in the first 2 years of growth hormone therapy. Okay, so hopefully everyone will be able to answer everything correctly at the end of the conference. Please look for the pre-conference survey link. I'll put it in the chat below. If you can quickly get a chance to do that, that would be great. And so I will stop sharing, and now I'll introduce Dr. Rappaport. So Dr. Rappaport is our keynote speaker today. He is a professor of pediatrics in the Division of Pediatric Endocrinology and Diabetes in the Jack and Lucy Clark Department of Pediatrics at the Icahn School of Medicine at Mount Sinai and Mount Sinai's Children's Hospital. He's the Emma Elizabeth Sullivan Professor of Pediatric Endocrinology and Diabetes and Director of the Growth Center. Dr. Rappaport received his medical degree from SUNY Downstate. Welcome back. And he completed his residency training in pediatrics at the Schneider Children's Hospital, Long Island Jewish Hospital, Hillside Medical Center, and his fellowship training in pediatric endocrinology at St. Christopher's Hospital for Children in Philadelphia and New York Cornell Medical Center. He has published numerous articles, chapters, including chapters in major pediatric and pediatric endocrinology textbooks. Dr. Rappaport will be presenting growth hormone from infants to adults.
Thanking Dr. Chin and her colleagues for inviting me. I always have, as you know, very fond memories of Downstate, and I need to say no more about lowering expectations, but I don't know if you heard my story of Downstate, which is not all that interesting, except for the fact that when I looked at your website, I saw this image on the website, so I didn't realize that What we did many years ago, that is play volleyball, is now apparently a thing at Downstate, maybe. And then I think we stop when I show this new insignia and what it means. And I think I will stop with that discussion as well. We're starting a few minutes before 10, and I'll try to finish whenever you feel like you had enough. Otherwise, we'll go to the evening. But the objectives of this speaking engagement today is to identify some factors needed for normal growth, describe some of the methods for evaluating the hypothalamic pituitary growth axis, talk about some of the FDA-approved indications that Dr. Umpachitra very beautifully described before, some monitoring issues, and then perhaps talk about transition from pediatric to adult care. So this is the outline, growth assessment, growth disturbances, and then growth hormone IGF-1. And if there's time, we'll talk a little bit about some other emerging treatment options. So why growth? We're so focused on growth. And we and others feel that a child's growth is one of the most important aspects of the general pediatric visit. If you have concerns about growth, this is the leading concern why patients are referred to pediatric endocrinologists. Dr. Lynn Levitsky also had the same concern in another paper that she wrote. Abnormalities of growth are sensitive indicators of physical well-being during childhood, and they may also be the harbingers of later adult disease. So to start, we start with the normal assessment of a child and what are we looking for. So the growth assessments start with measuring, and you have to measure them carefully. Those of you who are in pediatrics know that it's not so easy to measure. You have to differentiate between whether you measure a length or a height. Weight is somewhat easier, head circumference, and then BMI gets plotted on your electronic health record now. Important would be to plot these points carefully. And longitudinal growth points are probably the single most important tool when we make a diagnosis of abnormalities of growth. These growth points should be plotted on appropriate growth charts. So if a person has a certain condition, it should be on that condition. If you're in Southeast India, you should plot it on a curve that's appropriate for that part of the world. So those of you who know it's important to have a good stadiometer to measure length or height to make sure the person is in a good position with the heels back to the wall, straight position, and the eyes perfectly perpendicular to this. It's called the Frankfurt plane. Of course, no shoes. So this is a chart for children born SGA, and we use this Usher-McLean curve for that. And the definition of SGA is being more than 2 standard deviations below the mean, which is actually 2.3 percentile. For Turner patients, we have this Turner growth chart that is from Lyon and colleagues. This is a growth chart that one of my colleagues in India sent to me about girth height charts. Next, we go into the growth assessment in fetal life, infant life, childhood, and adolescence. And it's important to look at growth velocity. For a rough value, 10, 5, 2.5 inches per year is really a good way to remember, but it's much better to look at a growth velocity chart. So usually I ask my patients and their parents, what does one need to grow well? So number one is nutrition. So globally, poor nutrition is by far the leading cause of abnormalities in growth. You need to have a normal psychosocial environment. Any chronic illness can affect your growth. So if you have kidney disease, heart disease, you need to have normal chromosomes. And only lastly, do we look at hormones to make sure that they're normal. So longitudinal growth points, sex and population appropriates are the best way to assess growth. And yes, that starts in utero. So you could measure in utero the growth of a fetus. If they're not growing properly, that term is intrauterine growth retardation. Some, but not all of those children may be born small for gestational age. If there are any questions in between, feel free to stop me and we could discuss them, but otherwise we'll go on next to short stature. Sometimes it's obvious, sometimes it's not. So the definition of short stature growth is entirely arbitrary, and it could be a weight or height less than 3rd, 5th, or 10th percentile, or a height less than 2 to 2.5 standard deviations. Growth velocity less than 50th percentile or less than 0 standard deviations will ultimately lead to poor height. When you do a history, it's important to talk about maternal and fetal history. Is there a problem that the mother has? Is she on any medication? Does she have any illnesses? Perinatal issues, birth weight, length, and head circumference should be obtained. Any pertinent positives in the past medical history. Review of systems. For the family, and we like to go to the siblings, parents, as well as grandparents, you ask about stature as well as the age of onset of puberty. Generally, women are more accurate. Guys tend to overestimate their height. On physical exam, you measure weight, length, but also get upper-lower segment ratio, arm span. Note any dysmorphic features. And for any patient, look at whether the thyroid gland is palpable or not, and what the pubertal status is. So to investigate, this is a baseline evaluations. SED rate, we always check that. And in part because a physician at Mount Sinai, Dr. Donald Gribbets, initially described short stature as a presenting form of inflammatory bowel disease. You want to exclude celiac disease and baseline endocrine evaluations. Probably in the future, probably not so distant future, one would look at whole exome sequencing or next generation sequencing as part of the initial evaluation. Certainly not now. The bone age is important. And I saw there was a question about the bone age before. So this would be just a baseline evaluation. So I'll spend the next few minutes on this chart because these would be by far the two most common conditions that you will see. These are children that some people refer to as normal variant stature, familial short stature, and constitutional growth delay. They both present because they're short. There frequently is a family history. The key is that if you follow these, they have a fairly normal growth rate. They grow parallel to, but below a normal growth curve. What differentiates between the two is the bone age. In familial short stature, it's equivalent to the chronological age. In constitutional growth rate, it's delayed, sometimes approximates the height age. Height age is the height if you take a point and go to the 50th percentile. So a 10-year-old who's the size of an 8-year-old may have a bone age of an 8-year-old. If you follow them without any treatment, the adult height will be equivalent for familial short stature and will be normal for somebody with constitutional growth delay. Treatment is somewhat controversial. If you are late in starting puberty, can you treat temporarily with estrogen if you're a girl, testosterone if you're a male? And unfortunately, the diagnosis of idiopathic short stature, which you'll hear me complain about several times, does not exclude these conditions from its diagnosis. But these two conditions, by far, the most common patients that you'll see for the evaluation of stature. So here's a child with constitutional growth delay. You can see my pointer, can you not? They grow parallel to the norm. They deviate somewhat when the rest of the population starts going into puberty, and they do not. They will start puberty a little bit later, but wind up at a perfectly adequate height. Those with familiar stature also may grow parallel to, but since puberty will start at an appropriate age, they will likely wind up somewhat shorter than the general population, but okay for the target height for how tall the parents are. We used to say familiar short stature and stop at that, but I think now we need to look for familiar inherited causes of growth failure. I mentioned earlier that pubertal assessment is very important in part because it so well relates to growth. So if you look at girls, they start puberty somewhat earlier. They have a peak growth response somewhat earlier, and they stop growing somewhat earlier. Boys start somewhat later, have a peak growth hormone at about a bone age of 13.5, and then ultimately stop growing. Those who have early or late puberty will have a lesser peak in growth velocity. So therefore, it's very important to have an accurate pubertal assessment when you evaluate somebody for abnormalities in growth. So these are two growth charts. On the one on my right, hopefully your right as well, you see this child is not only short, but it's getting further and further away from the norm. Clearly, this child will need an evaluation. This child is short, but maintains his height percentile. Is this a candidate for growth hormone treatment or evaluation? Perhaps. Perhaps if this child was born SGA, it might be. So most patients that you evaluate for short stature may have a normal growth variant or non-hormonal cause for it. This is a classification of short stature, but any classification is fine. There are many different textbooks. I like this one for the following reason. Growth failure could either be proportionate or disproportionate. Disproportionate usually involves skeletal abnormalities. But of those with proportionate short stature, the question is the onset prenatal? If it's prenatal, then it depends on the mother or the baby. The mother could have any kind of disease, infection, exposure to medication, or the baby has some dysmorphic or chromosomal abnormalities. Once these are identified, these children may or may not show adequate catch-up growth. If the onset, however, is postnatal, and I cannot stress nutritional causes strongly enough, as I mentioned before, globally, that is by far the most common cause of growth failure. Any chronic disease can affect your growth. And in fact, we've been talking about that for many years, but frequently we don't know exactly what the pathophysiology of that is. Exposure to drugs, psychosocial dwarfs, and lastly, endocrine and metabolic disorders. Now, of the skeletal dysplasias, here is from a standard textbook, and that is why they don't have a black thing around their eyes. But some of them, Russell-Silver syndrome, these children are born small for gestational age, Prader-Willi syndrome, and Noonan syndrome are, in fact, candidates for growth hormone treatment. This is from an original paper on this. Can you guess what condition this patient has? Since I can't hear, I'll just assume you guessed. These are the original 6 patients described by Professor Turner, also described by Professor Ehrlich for Turner syndrome. This is a baby with Turner syndrome, where you see the redundant skin from a resolving cystic hygroma. I always ask whether the baby had swelling of the hands and feet, especially a girl baby, which may be the initial presenting sign in perhaps a third of patients. It does improve with age, so it doesn't persist. So it's important for parents to know this right away. Many of you know this woman. So the question for her is, does she have Turner syndrome? I can't see who's putting what in the chat. Who thinks the answer is yes? Raise your hands. Well, hold on.
You guys can unmute or chat.
Who thinks that she doesn't? So the correct answer is that you cannot tell. So therefore, the take-home message from this slide is that even in the absence of obvious features of gonadal dysgenesis, you should certainly consider Turner syndrome in any short girl. If you want to see her, her name is Lady Innes. She was painted by Thomas Gainsborough, and her painting is currently at one of my favorite places in the city, the Frick Collection. Next, we'll focus on growth hormone and IGF-1 and these disturbances. So this is, for the next few slides, a hypothalamic pituitary axis. It starts with the hypothalamic pituitary complex, and there are transcription factors that regulate growth hormone releasing hormone. There are growth centers that affect pituitary, so there are growth hormone gene, growth hormone receptor, hormone receptor, and other transcription factors. If everything functions normally, you have the production of growth hormone. Growth hormone then attaches to its binding protein and goes with it to its receptor, and it attaches there, where transmembrane and intracellular growth hormone receptor is seen. And once growth hormone attaches to it, you have signal transduction, JAK-STAT, and MAP kinase, resulting in the production of IGF-1, but also IGF binding protein, many of them, but the binding protein 3 most relevant, and an acid labile subunit. And then they join together and are transported in this joint tripartite entity until the end of the bone, which is where they affect growth by attaching to its receptor, the type 1 IGF-1 receptor. And there's also another gene that Dr. Umpachitra mentioned, the SHOX gene, which can also affect growth. So clearly, you have a very large hypothalamic pituitary pathway, so you could have abnormalities anywhere along this pathway. The SHOX gene Dr. Umpachitra mentioned is this homologous gene on X and Y, does not go X in activation, and you need 2 active copies for normal growth. It's expressed in developing bone during gestation. It is involved in regulation of chondrocyte proliferation. Obviously, the patients who are missing these would be the obvious patients. So, for example, a child with Turner syndrome will have a mixing or SHOX haploinsufficiency. Then there are all of this host of transcription factor, PIT1, PROP1, genes involved in anterior pituitary development that may result in not only growth hormone deficiency, but other pituitary hormone deficiencies. There is hypothalamic control of GHRH, there's a GHRH receptor, and then the GH1 gene, which can also have abnormalities. Once growth hormone is produced normally, it binds to a receptor dimer, and I could see it up here. It leads to the activation of this complex and the subsequent phosphorylation events. Obviously, abnormalities in it can be described and have been described, such as, for example, NSTAT5B. As you see, it also affects metabolism, cell proliferation, in addition to IGF-1. So you could see STAT5B over here. Now, if you have this, what are the things that one could easily measure in this whole pathway? Growth hormone, certainly we could measure growth hormone. And there was a question before, do we ever measure randomly? And the answer is almost never, unless it's a baby in whom you think that the stress of doing a blood test will result in her doing her own growth hormone stimulation test. You could measure IGF-1. You could measure IGF-BP3. You could measure ALS. You could measure even growth hormone binding protein circulating in the serum, and that represents the extracellular portion of the growth hormone receptor. And you can measure a SHOX gene, and we've done some studies in that. The reason we don't measure growth hormone is on this slide, because if you look at a 24-hour secretion, it is pulsatile in younger female, younger males, and older females, older males. So if you measure it at any one point, a random level is not helpful unless you happen to catch a peak. So in general, we almost never measure that. So how does one make the diagnosis of growth hormone deficiency? First of all, it has to be a patient that's referred to you with short stature, right? And they have a low growth rate. You need to evaluate them longitudinally for at minimum, I would say at least 6 months, perhaps longer. The longer, the better. They have low IGF-1, low IGF binding protein. And then you do a growth hormone stimulation test, or you look at spontaneous growth hormone secretion. So, and if that's abnormal, then you could see that it forms the diagnosis of growth hormone deficiency. And normally, should you be live and in person, I would ask you, is there anything missing on this slide? Give you a second to think, but the obvious answer is, yeah, what's the peak value? And that is actually a moving target. It used to be initially 5, then 7. And now if you're asked on a board exam, the answer is 10, although there's a lot of controversy about that. And I have another slide, which I will not show you, that tells me that the peak level at which you diagnose growth hormone deficiency is directly related to the availability of growth hormone. What growth hormone stimulation should you do? There are more than 60 to 70 different growth hormone stimuli that have been reported. We reported a paper with Dr. Yao looking at arginine and L-DOPA in about 350 patients. It doesn't matter which you use, but the idea is to use at least 2 different stimuli. Here's a 3-month-old boy with poor growth, normal birth weight, born by breech, and in the newborn period had hypoglycemia, jaundice, and a small penis. So the clues for this with a baby with at the time of hypoglycemia is the jaundice, and there's a lot written about what causes jaundice in neonates. We have some of these babies who are seeing GI and already had liver biopsies, whereas in fact, all they had is deficiency in pituitary hormones. Atypical genitalia would be the other clue. So at a time of low glucose, and it's important to teach the neonatologists and people in the emergency department that before you treat hypoglycemia, please draw a sample to measure for hormones. If you're not sure which, save it and we'll be happy to help you with that. But at the time of hypoglycemia, this baby had low growth hormone, low cortisol, T4 and T3 were low without an elevated TSH, and prolactin was high, suggesting that there may be not more than growth hormone affected in this baby. IGF-1 is somewhat controversial because the low value of IGF-1 may somewhat cross with that for normal in infancy. So what would you do next? Since I can't hear you, I'll just assume you're guessing various things. But one of them is perhaps do a genetic evaluation to see what the cause was, and certainly do an MRI. I think there was a question before whether or not an MRI is always indicated. Certainly, if there's a chance of pituitary defect, you should always get an MRI. This baby also had growth hormone stimulation test with fairly low values, so clearly not a borderline case. And this is the pituitary MRI. If you see this, the anterior pituitary, the posterior pituitary, bright spot, connection to the hypothalamus. So we have actually a conference with our neuroradiologist to review every single one of our MRIs. So this is an actual baby that I saw, and it was a time before electronic health record, and I taught everybody to make these perpendicular lines for their growth points. And you see this baby is born not small, so babies with even congenital growth hormone deficiency are not born that small. but the baby is not growing well. And by about 17 months of age, the baby was started on treatment with growth hormone. So how about growth hormone treatment? So it started in treating rats who were given growth hormone and they became very large. First, human pituitary was purified in 1956. And in 1958, Rayburn published this letter to the New England Journal where he treated this boy with growth hormone. This is the growth hormone. I showed that growth hormone grew much better. Many different companies make growth hormone. This is just some of them. It could be given with a needle and syringe, with a pen device, needle-free device. Inhaled transdermal is not available, but Dr. Barkman will be talking about various growth hormone preparations. Long-acting growth hormone and perhaps oral, we'll mention in a little bit. I will not spend much time on this. This is some of the long-acting growth hormone preparations, usually lasting 7 to 14 days. Some of them are marketed. Some of them have been approved already. And as I mentioned, Dr. Borgman will be talking about this. So this is that patient I showed you initially. Was very short, grew better, stopped when growth hormone was stopped, and then continued to grow very well. So I could spend an hour, but I won't, on this one slide. When should other pituitary hormones be replaced? And when should growth hormone be stopped? He wound up much taller than his parents. He also was not so thin, so growth hormone does not prevent overweight. This is a summary from Roland Pfeffler, who looked at growth hormone. Now, we want you to focus in on this part, showing the mean duration of treatment and the height gain. The longer treatment duration, the more height gain you had. So the answer from this is that diagnose it early, and the earlier you start treatment, the better. This is from Nellie Moras and Mary Lee Vance, a fairly old slide, but it makes a point. You start treatment, look at growth velocity. You could grow best in the first year, somewhat less as treatment goes on, and the height standard deviation improves. But not to zero, not to zero. So to improve results, what can you do? First, treat as soon as possible. Should you increase the dose? A lot of parents ask me about that. We want to individualize it and measure IGF-1. There's really no good reason and no hard data to show that high IGF-1s are dangerous, but still we want to keep it in the normal range. Next, you stop growing when your bones are fully mature. So if you do something to delay bone maturation, will you reach a better growth? And I'll mention some of this a little bit later if possible. These are the FDA-approved indications in the United States and in Europe. US has some that Europe does not have, such as Mainland Syndrome and Idiopathic short stature. And this is the timing of when they were approved. Sorry. So how about small for gestational age? It was mentioned before. And here's the difference between the US and the European approval. The age at start differs, 4 in Europe, 2 in the United States. And the dose, a huge dose in the United States that was approved, double of what's done in Europe. Here's a patient of mine, and you can see that he's growing here at about close to the 10th percentile, 5th to 10th percentile, which you might say is not so bad. But look at his parents, look how tall they are. So because of that, we put him on treatment, and within 1 year of treatment, his height went between 25th and 50th percentile. So are you convinced that it works? Of course not. This is just one patient and all that. So then what we did is we did a multi-center trial, many centers. We had 139 patients. We looked at glucose tolerance as well as insulin resistance. And we used a high FDA-approved dose for 1 year. What we found is that the height SDS improved by about 0.7 SDs. IGF-1 increased, but remained in a normal range. And similar changes were noted in weight and BMI. So it was well tolerated. The delta height SD at 3 and 6 months were predictive of the 1 year height SD. And as you know, many of these children go on gastrostomy tube. We found that underweight children grew as well as the normal weight children. So here's that one patient that I showed you. And look how well he did. He did very well, taller than mid-parental heart, even though he did not become obese. Dr. Anita Hoken-Holega, who has written most on SGA in the world, summarized on this for one of our publications. Most children do best. And this is from Roland Pfeffle, again showing the height gain depending on the years of treatment. So treat early. Now, why should everybody be interested in SGA? And that is because birth weight and birth length does have consequences for you as an adult. This is the fetal origins of adult diseases. So the non-growth adult correlates with being born small, impair intellectual development. If you look at equally premature babies, those with a lower birth weight did worse. Lots of studies on that. They have impaired bone mass at 66 years of age. Regardless of how much vitamin D you take, your birth weight may affect your bone mass. Impaired lung function, stress response, perhaps cancer, and certainly abnormalities of insulin metabolism, initially reported by Dr. Barker, calling it the Barker hypothesis. So important to watch that. Dr. Upachitra mentioned SHOX deficiency. I will not go into it in detail, and I showed you this slide before. We looked at SHOX gene variants and found that they did as well as the other children. So I won't stop on that. Now, these are conditions that are not FDA approved, where growth hormone was tried. Down syndrome, some of those papers coming from Downstate. patients with 18q deletion, hypo or achondroplasia, Crohn's disease, cystic fibrosis, CAH, wound healing. And as you know, there's a whole industry of anti-aging, so we don't recommend any of that. In France, they had a cohort of patients with hypochondroplasia. Maybe there's a way of treating them now, but then we did not think that that would be important. So growth hormone treatment, certainly in FDA-approved indications, works very well. It does increase adult height. Now, IGF-1 was also approved for treatment. It should be given once a daily, twice daily, and who are the candidates? So the obvious candidates, patients with Larone syndrome. Sri Larone reported these patients who appear somewhat like this. And so if you have enough growth hormone, but a problem with the growth hormone receptor, either extracellular, intracellular, or transmembrane, or abnormalities in STAT5, growth hormone response element, these would be the obvious cases for treatment. And here's a patient that I saw at Sinai. He was 11 when I met him, but he stopped growing at about 2 years of age. At age 3, he was correctly diagnosed with growth hormone deficiency, and he started on growth hormone treatment. The history was unremarkable. He was not low birth weight. He had no jaundice, hypoglycemia, or a small penis at growth. Developmentally, he was doing well. Family history showed no consanguinity, relatively unremarkable. Look how short he was, more than 5 standard deviations below the mean. On the exam, he was fine. We talked about measuring upper to lower segment ratio, arm span, looking at dysmorphic features. He had none of that. He was not in puberty. So if you look over here, he had a growth hormone stimulation test. Very low peak response, low IGF-1, normal.
You're muted, Dr. Rappaport.
Okay, I know my voice is going a little bit, but so he had a low IGF-1, low growth hormone. We started on growth hormone, look at his growth rate, went from 3.5, 10.6, and then he stopped growing. And they measured growth hormone antibodies, and they were positive. Almost never do you see growth attenuating growth hormone antibodies. And then ultimately, what was done is they found that he had a homozygous deletion of growth hormone 1 gene. Took a while until it finally got put on IGF-1. And on IGF-1, his growth rate improved. So this is growth hormone GH1 deficiency, idiopathic growth hormone deficiency, which could be idiopathic, congenital, or genetic, or acquired. And he had a mutation of the GH1 gene. Autosomal recessive, IGF-1A deficiency. Severe short stature, positive antibodies. That's what the gene looks like. But we didn't do so well with him. Look at this, he improved, did okay, wound up extremely short. We are very upset about that, but in fact, that is the standard. If you look at this, these patients wind up -5, -2, -8 standard deviations below the mean. And even in Europe, minus 3.4 standard deviations below the mean. So much more common than that is something that you'll see tomorrow in your clinic. There's a kid who comes in who's very short. He's previously had a growth hormone stim at a normal value. So what we did is we re-stimmed him and found an abnormal value at the time when he was in early puberty. We put him on treatment, and we're actually developing a number of situations where a repeat stimulation test may be helpful. Look at this kid. It's short, not that short, but look how tall the family is. So for the family, it's quite short. Growth velocity, all below average. Here's this other kid, also quite short, coming from a short family. Normal IGF-1, normal IGF-3, normal shock gene, normal growth hormone stimulation. So IGF-1, if you want to know, because endocrinologists always want to see numbers. It's not good enough that you say low or high. It says, yeah, but what was the number? Here are the numbers. Peak of 43, solidly robust. Growth hormone binding protein low, and we looked at growth hormone receptor and STAT5B, and they were normal. So what does this child have? We like to call this growth failure of unknown etiology, or most people refer to us as idiopathic short stature, which was FDA approved. And we certainly should do more genetic evaluation for this child. We published a paper a year ago with Professor Savage and Jan Martin Witt on idiopathic short stature, showing that the more you evaluate, the fewer cases are truly idiopathic. So let's go back to this for a second. Growth hormone, IGF-1, IGF-BP3, acid levodopa, that's what this patient had. High growth hormone, low BP3, low IGF-1, normal shocks. Normal growth hormone receptor and post-receptor findings. I mentioned this before. I don't know, maybe we'll spend a few minutes on this. So if you only grow until your bones fuse, why don't we stop or delay the fusion of bones? Is that something that can be done or should be done? So Jack Janowski published a paper in the New England Journal showing that LHRH agonist for 3.5 years increased adult height, but decreased bone mineral density. This was a kind of a seminal case where this young man at the age of 28, this is his point, continued to grow. Why? Because he had an estrogen receptor defect. His body did not recognize estrogen, so the bones did not fuse. He kept growing. So that looks at aromatase and estrogen synthetase, and that's expressed in multiple tissues. And then in Wickman and Lancet produced this paper where he treated patients with testosterone, some with an aromatase inhibitor, some without, and those with the aromatase inhibitor had a better adult height prediction. That led to a whole bunch of papers. One of them with Nelly Morassi I was involved with, where we treated placebo control or aromatase inhibitor, and we found that those with the aromatase inhibitor had a better predicted adult height. Still, I think there are insufficient papers that take these patients to adult stature, and this is a Cochrane summary showing that you need to be quite careful about this without adequate data. So let's go back to this schema, which I seem to like. So growth hormone releasing hormone, we actually tried about 20 years ago, treatment did not work all that well. Growth hormone treatment, the standard treatment. I mentioned a little bit about IGF-1 treatment. And what's in the future is attacking the growth plate and perhaps even using oral secretagogues. This is a famous painting. Achondroplasia, not so common, autosomal dominant. The mutation is this FGFR3 receptor. And there are some treatments now, like CNP analog, C-natriuretic peptide analog, and Matrilin. And this slide I borrowed from Brad Miller. And this medication, in fact, has been approved for treatment in patients with achondroplasia. That it increases that CNP-related membrane, so decreases FGFR3. The next thing that will be coming along is something called Matrilin, which is an extracellular matrix protein, which is fused to IGF-1 at the growth plate. And we'll be starting some studies with an oral agent that will increase GHRH. And for those with only a partial or mild pituitary defect, may show a response. We actually wrote a little editorial about that a year ago. So what's the important things, take-home message for growth failure? You need to make a correct diagnosis. You need to discuss with the families the treatment options and expectations. If possible, treat early, and a younger age, bone age, the better. Consider individualized plan and precision medicine. Monitor carefully and reevaluate whenever is needed. We monitor IGF-1, glucose, and for the development of other pituitary hormones. For GHRH and aromatase inhibitor, more data are needed, and use caution if you use them. In medicine, we always want to do no harm, so I'll show you this slide twice. Side effects are possible, but relatively rare. If you look at pseudotumor cerebri, peripheral edema, joint pain, very rare. Give Amvlit report for a patient with Prader-Willi syndrome who died on growth hormone. In France, there's a concern about abnormalities, which most of the colleagues don't share with Jean-Claude Carrel. In general, growth hormone is quite safe. And in fact, if you look at adult mortality, morbidity, as Shlomo Melmed looked at, no increased risk of mortality, cancer, stroke in growth hormone deficient patients who receive prior pediatric growth hormone treatment. And there was a paper last year in JAMA reporting some cardiac anomalies. Again, those papers have not been substantiated yet. There are epidemiological studies associating high IGF-1 level, especially associated with low BP3 level, with increased incidence of cancer, prostate, lung, breast, colon, but not in growth hormone treated patients, And in fact, in Ecuador, Jaime Guevara and colleagues published the fact that those who have a growth hormone receptor defect have a reduction in cancer and diabetes. So it's interesting. So now we'll switch gears a little bit. I don't know how many of you know this guy, and I'm a big fan of his. But he developed growth hormone deficiency at 11 years of age. And now he's probably one of the top football or soccer players in the world. So we'll switch to the adult part. He's an actual patient of mine, did not grow well, slowed down, had a twin brother, much taller than him, diagnosed, treated, did very well. So once he reaches this height, should we stop treatment? Should we consider treating him as an adult? Which brings up the question of adult versus childhood versus adult onset growth hormone deficiency. So here are some of the questions. Should we stop? When, why, how? Should we retest, resume, and transition? Certainly, growth hormone is important throughout life. This is Tzvi Tzadik showing that even in advanced age, growth hormone secretion is present, lower, but not zero. This is my friend Ron Rosenfeld, who looked at patients who were growth hormone deficient and stopped treatment. The mean age of 8 years follow-up, they develop increase in fat mass, decrease in muscle mass, decrease in bone density. So there are metabolic reasons why you would continue. Tauber and colleagues showed that if you have organic growth hormone deficiency and you test less than 5, when you retest, it's very likely you'll find growth hormone deficiency again. However, with idiopathic growth hormone deficiency, especially if it's only one agent that you're deficient in, it's likely you will test normal. How you test depends, and Beverly Biller wrote this paper about different agents. You need to have different cutoffs for what normal is. If you have more,
Sorry, Dr. Rappaport, we need to wrap up.
yes. You had a question?
Oh, no, I'm just saying if you can start wrapping up.
Yeah, it is wrapping up because it's like 12 minutes to 10. I'm aware of the clock. So if you have 3 or 4 additional hormones, just a low IGF-1 will be sufficient. So, but remember, should we restart? I told you that low IGF-1 are associated with this, not in growth hormone deficient patients. But in fact, Anders Ewell showed that low IGF-1 is also not good for you. It leads to increase in cardiac problems. So we do recommend stopping growth hormone when growth rate is less than 2, bone age is fused. If there is organic GHD or you have a gene defect, then you don't need to. You can change to the adult dose, which is significantly less. You should retest different agents, check an MRI, check DNA. You may want to do a DEXA scan, look at cardiac status, carbohydrate metabolism. And the answer is yes, we do recommend treatment at low dose and titrate to IGF-1 levels. So Vivian, if that's okay with you, I'll wind up here. These are the objectives that we had. And hopefully these have been met. And now you might have a coffee break where you'll be giving chocolate. This is just an old slide showing you the correlation between Nobel Prize and consumption of chocolate. More chocolate you consume, more Nobel Prizes you have. Thank you.
Thank you.
That's the last slide.
Thank you. Does anyone have any questions? I have some questions in the chat.
Okay, should I stop sharing?
Sure, I will read them out to you.
Okay.
Even though SGA is an indication for treatment, I find it really difficult to convince most insurance companies. Any advice?
Yeah, just be tough on them. I think we're actually just writing a new consensus statement on SGA, making a strong case for growth hormone treatment.
The next question is, why would you suspect that the lady from the Frick collection has Turners? Was she short?
Why what?
Why the lady in the painting would even be considered for Turners? Was she short?
Well, the point was that she doesn't look as if she's got Turner syndrome, but in any short child, you should consider it, even if there are no obvious features of gonadal dysgenesis. And I really have no idea whether that lady does have Turner syndrome or not.
Mm-hmm. In a kids with a weight less than 10 kilograms, do you think a growth hormone stimulation test with one agent, glucagon only, for 3 hours is appropriate, or should we always do 2 agents?
Well, in general, we always want 2 agents. If you have a low IGF, low stimulation test, and you do an MRI, if the MRI shows an abnormality, having just a low IGF will suffice. In a very young infants, it's somewhat depending on what other suggestions for growth hormone deficiency you have.
Mm-hmm. What is the clinical relevance of using IGF-1 Z-score in the initial evaluation of a child with a growth velocity that is low for age?
So I do like to use the IGF-1 Z-score, although there's concern about how sensitive or how good these IGF-1 levels are. And low IGF-1 and somebody's not growing well, it would suggest me to do a growth hormone stimulation test sooner. Especially if they've already started going puberty. So we always like to correct pubertal levels with when the peak growth hormone level is. Isn't it amazing? In all areas of endocrinology, we have age-adjusted normals, but we don't for growth hormone. And that's why a peak growth hormone level of 9 in a prepubertal child, I'm not sure how important that is. Peak level of 9 in somebody's testosterone is 200, I think is quite relevant.
Mhm.
Does that answer the question more or less?
Does that answer the question? Let's see. I'm not sure, but sorry, as a background to the previous case we discussed with the.
Let me just hear about insurance companies. Insurance companies are, as you know, in business to try to reject as many cases as possible. So they have a set of rules by which they agree. And if they say that you need 2 stim tests, they will not relent on that. Occasionally, they tell us that a patient reached a good adult height, they will stop treatment. So it's important, and it's important not to allow insurance company to drive clinical practice.
Right.
Carolina, I'm glad you guessed Messi.
I'm sorry?
I'm just looking at the chat. And
Right. So I think there is another question about using growth hormone to assist in weight loss.
absolutely not, and which is why I showed you that even on growth hormone treatment, some kids do become overweight and obese. So people have tried 20 years ago to look at growth hormone as a weight-reducing agent. I do not believe in that at all.
Have you used BID dosing for infants and neonates under a year with growth hormone deficiency, especially with hypoglycemia? Is there any?
I have not. I think the physiological half-life of growth hormone increasing IGF-1 frequently prevents hypoglycemia. If they're hypoglycemic on daily growth hormone dose, we may want to look for other causes of hypoglycemia. So I have not.
In your experience, how often have your kids on treatment developed SCFE or pseudotumor?
I have never seen a kid with SCFE or with pseudotumor cerebri. And I must tell you that as a routine, I start every child on half a dose of growth hormone for 2 weeks and then go on to the usual dose. And knocking plastic or wood, I have not seen any patients with either of those.
Yeah, it's something rare. I have not seen either. Would you prefer to check IGF-1 when the patient is fasted or a random blood sampling?
It actually doesn't matter. Studies have shown that IGF-1 is not so much affected by fasting. However, I do think there is a tremendous variation in the various commercial labs doing IGF-1. There has been a global attempt to try to harmonize IGF-1 assays, which has not yet happened. So I would repeat it in a different laboratory.
Someone else wants to know if you have been using Skytropha.
Well, we are actually doing some studies with Skytropha, and I haven't yet started. I'd like it to be out a little bit longer.
Any indication for growth hormone in a patient with short stature without growth hormone deficiency and ovarian insufficiency, but has normal karyotype, not Turner's or mosaic?
Well, so there are occasionally these patients in whom we don't know what the cause is, or not deficient, in whom we may consider using growth hormone, but I think that case probably needs to be a little bit more deeply looked into. At 5'3", it's unlikely. Oh no, that's another question. I'm sorry.
Oh, no problem. If you want to discuss that case too. In an ISS boy diagnosed late with approximate bone age of 16 for a 15-year-old who is 5'3", late Tanner stage, have you used AI to slow down epiphyseal closure without growth hormone?
So the answer is no. I would tell those parents that at bone age of 15 and 16, we would stop growth hormone treatment. We would not start growth hormone treatment. Any kind of intervention such as eyes will make a very small difference in the adult height that you reach. If you have 5 growth potential left, starting it may make more sense. If you have only an inch left, then even if it has a 10, 20, 25% chance of improving that, it's such a small chance, I'm not sure it's worth doing it.
Okay, I think we're out of time. It's 11 a.m. Thank you, Dr. Rappaport. I think we can take maybe a 5-minute quick break. I'll introduce Dr. Umpai Chitra. She is a ABP board certified in pediatric endocrinology and general pediatrics. She completed her pediatric residency and pediatric endocrinology fellowship also at SUNY Downstate. Dr. Umpai Chitra is an associate professor of clinical pediatrics and currently serves as the director of the Division of Pediatric Endocrinology and the fellowship director for our pediatric endocrinology training program. And she also serves as a medical director for our endocrine specialty center for newborn screening for the New York State Department of Health. Dr. Umpai Chitra will be presenting growth hormone indications, current indications for growth hormone therapy in children.
All right, thank you so much, Dr. Chin, for your introduction. This is my topic, for today's presentation, the current indication for growth hormone therapy in children. Disclosure, I conduct research for and received a grant from Janssen Research Development. However, my research for Janssen is a clinical trial that is unrelated to my presentation today. Currently, available recombinant human growth hormone has been used for more than 30 years. So it's, to be exact, it's like 37 years now. And its indication have been expanded worldwide, including growth hormone deficiency and many other causes of short stature. In some non-growth hormone deficiency short stature disorder, human recombinant growth hormone has been proved effective and is now used as a stand-in for the currently unknown pathophysiologically appropriate treatment. So this slide shows the list of the indications for growth hormone treatment in children. There are 8 of them, and these are growth hormone deficiency, chronic kidney disease, Turner syndrome, small for gestational age, patient who failed to catch up to normal growth percentages, patient with Prader-Willi syndrome, patient with idiopathic short stature, CHOC gene haploinsufficiency. CHOC gene is the short stature Homeobox containing gene, and Netherland syndrome. So the first indication was approved in 1985, so that's approximately 37 years ago. And it remains the primary indication. Growth hormone deficiency is a clinical diagnosis, and you would have to rely on a detailed medical history, clinical features, oxological analysis, biochemical tests for components of the growth hormone and IGF-1 axis, and also radiological assessment of skeletal maturation, and also an assessment of pituitary anatomy using MRI. So it occurs approximately 1 in 3,500 children in the US who are diagnosed to have growth hormone deficiency. Around 20% would have organic causes and 80% would have idiopathic growth hormone deficiency. And the aim of treatment would be normalization of height during childhood and attainment of adult height within normal range after the treatment. At the present time, we use what is called growth hormone stimulation test to help diagnose growth hormone deficiency. And the recognized criteria for the growth hormone deficiency is a response of less than 10 nanogram per milliliter to 2 different stimuli for growth hormone secretion. This is the list of the agents used for the stimulation test. For example, clonidine, levodopa, arginine, insulin, and glucagon. These agents increase growth hormone secretion either at the hypothalamus level or pituitary level. I put up the current consensus, Pediatric Endocrine Society and Growth Hormone Research Society recommend the dosage in the range of 0.024 to 0.05 milligram per kg per day. And the greater efficacy can be achieved with the higher dose, with more physiologic injection frequency, and also with the initiation at a younger age. The higher dose can be used in adolescents with late diagnosis and diminished period of time for catch-up growth. The second indication, this is the first non-growth hormone deficiency growth disorder for which growth hormone was approved for use by the US FDA. And this was approved in 1993. Half of the affected individuals who do not receive growth hormone treatment would attain adult height below -2 standard deviation. Children with the stage 3 to 5 chronic kidney disease or those who are on dialysis should be candidates for growth hormone therapy if they have persistent growth failure. Once other potentially treatable risk factors of growth failure have been adequately addressed and provided the child has still growth potential. So this slide is a busy slide. This is the slide that would show the factors that contribute to growth failure in children with chronic kidney disease. Let's start at the kidney level. When you have chronic kidney failure, you would have metabolic acidosis, you would have renal anemia, loss of electrolytes and the water, and this, can cause growth failure. There would also be an excess of IGF binding protein, IGF, which is the insulin-like growth factor binding protein. And also there'll be an increase of inflammation-induced suppressor of cytokine signaling. So this, will interfere with the growth hormone receptor expression and also will disturb the intracellular genase kinase, the STAT signaling pathway, causing the stage of growth hormone insensitivity, and then resulting in the reduced the functional IGF-1, and that will interfere with the growth. Malnutrition and also mineral bone disorder secondary to with the secondary hyperparathyroidism can also affect the growth. Glucocorticoid treatment also interfere with the integrity of the growth hormone and IGF-1 axis at different levels at the hypothalamus, together with uremia related inhibitory factor can interfere with the pubertal development, can give the delay of pubertal development, and delay puberty can interfere with growth. And definitely the prenatal and genetic factors can also interfere with the growth in children with this condition. So the growth hormone insensitivity in chronic kidney disease can be overcome by administration of supraphysiological doses of growth hormone, which stimulates IGF-1 synthesis and normalizes somatomedin bioactivity, promotes longitudinal growth, and of course improve the adult height. The dose is higher when compared with the dose used in growth hormone deficiency. That's why I put up the dose. You can see it's on the higher end, and it's given by the daily subcutaneous injections until the patient has reached their final height, or until renal transplant. The third indication is the Turner syndrome. This was approved in 1996. It was initially described in 1938 by Henry Turner, who described 7 women with infantilism, wet neck, and also cubitus valgus. This is a syndrome that I'm sure you have heard this, many times. Girls with Turner syndrome would have abnormal or missing X chromosome, resulting in short stature and ovarian failure. It occurs approximately 1 in every 2,500 live-born females. If left untreated, adult women with Turner syndrome would have approximately 20 centimeters, would be 20 centimeters shorter than mid-parental height, which is the genetic potential. Decreased sensitivity to growth hormone and IGF-1 had been hypothesized. The dose, I put up the dose just to show that, the dose that recommended to be used in this condition is also higher compared to the dose that we use in patients with growth hormone deficiency. Despite some evidence of subtle alterations in IGF-1 physiology, the growth deficit in individuals with Turner syndrome is now believed to result mainly from haploinsufficiency of 1 copy of the CHOX gene, located within the pseudo-autosomal region on the distal short arm of the X and Y chromosomes. Because the CHOX gene is located on the sex chromosome, so most women with Turner syndrome have only 1 copy of gene, the 45XO. So the CHOX protein is reduced, and the low level of this protein likely contributes to the short stature and skeletal abnormalities often seen in patients with this condition. I will discuss more about the CHOX gene in the next few slides. The next indication is Prader-Willi syndrome. I'm sure you have heard about this before. This indication was approved in 2000. Prader-Willi syndrome was first reported in 1956. It was described at that time as a syndrome of obesity, short stature, cryptorchidism, and idiocy in children and adults. The incidence is approximately 1 in 10 to 12,000 births. It is caused by an abnormality on the long arm of chromosome 15 that results in phenotypic characteristics dominated by hypophagia and insatiable appetite. And this syndrome is the most common of all syndromes associated with severe obesity. Affected children are characterized by obesity, hypotonia, short stature, hypogonadism, and behavioral abnormalities. Characteristic behavioral disturbance in this syndrome include excessive interest in food, skin picking, difficulty with a change in routine, temper tantrums, obsessive compulsive behaviors, and mood fluctuations. The reasons for short stature and positive growth response to growth hormone treatment in Prader-Willi syndrome patients remain unclear. The next indication is small for gestational age. This indication was approved in 2001. The definition has varied among medical disciplines, but our endocrine community has considered SGA to describe those born below 2 standard deviations for gestational age and gender for length, weight, or hair circumference. Approximately 90% of infants born SGA would undergo spontaneous catch-up growth to return to their genetic potential by the end of the 2nd year of life. However, most catch-up occurs by 9 to 15 months. So the remaining 10% would be those who are eligible for growth hormone treatment. The US is the, hold on a second. Okay, let me move to the next slide. Okay, so this is the gender specific intrauterine growth curves for girls and boys. This is the one that we use, I believe, for the length for age weight for age and also hair circumference for age. So those who already did the rotation in nursery or NICU probably have already seen this growth chart. The dose again, for this condition is higher when compared with the dose of growth hormone that we use in growth hormone deficient patients for, again, currently unknown reason. There is considerable variation in height gain after the treatment, and adverse events due to growth hormone treatment are not more common in this population than in other conditions related to growth hormone treatment. Now, the next indication is idiopathic short stature. This one was approved in 2003. The diagnosis is based on a process of exclusion. Except for short stature, these children apparently have no other discernible medical issues. Height of 2.25 or more standard deviations below the mean for age and gender, without evidence of any underlying diseases of growth hormone deficiency. And again, responses to the treatment are highly variable. And this is the indication that the US is the only country that has approved the use of growth hormone in idiopathic short stature. The next indication is the short stature Homeobox gene containing gene Hypothalamic insufficiency. This indication was approved in 2006, and this gene encodes the CHOC protein, which is a transcription factor. This gene is located, like I mentioned before, in the pseudo-autosomal regions of the distal ends of the X and Y chromosomes. It was first sequenced and suggested as a cause of short stature in girls with Turner syndrome and those with idiopathic short stature in 1997. Patients with this gene deletion tend to have shorter forearms and lower legs. This condition can cause short stature with a wide range of clinical presentations, varying from Lange syndrome, which is a severe mesomelic short stature caused by homozygous mutation, to Loriville dyschondrosteosis, which is the same mutation but heterozygous, to an almost normal clinical presentation, which is apparent idiopathic short stature. So in the early 2000s, there were several studies that demonstrated that approximately 2 to 3%, or could go up to 10%, depending on which population of patient that initially was classified as having idiopathic short stature, actually have CHOC gene deletion or mutation. This condition occurred approximately 1 to 2,500 individuals, and if left untreated, the average adult height would be around minus 1.8 to 2.3 below standard deviation. So this one, I got it from the internet. So this is called Netherland Deformity, which is the growth disturbance that causes the distal radius to tilt towards palm and ulnar bone and makes ulnar bone appear prominent dorsally. So this is the typical deformity that you would see in CHOC gene deletion. The next indication, and this is the most recent indication, for growth hormone used in children, is which is the Mainland Syndrome. It was approved in 2007. This was initially described by Jacqueline Noonan in 1968. That is like 54 years ago. When the 19 children with similar features, including pulmonary stenosis, ptosis, and low set ears, and short stature, were described. Approximately 50% of patients with Noonan syndrome have a mutation in PTPN11 gene on chromosome 12. This gene encodes an enzyme that involved in growth hormone and IGF-1 signal transduction. It occurs approximately 1 to 1,000 to 1 to 2,500 live births. Similar to patients with Turner syndrome, decreased growth hormone sensitivity has been hypothesized. So basically, we don't really know, the clear reason why growth hormone is working in this type of patient. And again, the dose I just put just to compare to the dose that we use in growth hormone deficient patient. The dose for this patient will be on the higher end, and it can go up to 0.067 milligram per kg per day. The patient with this syndrome would have typical facial features, for example, hypothalamism, downward slant eyes, and low set ears. And of course, they will have short stature and congenital heart defects. Even though there was a concern about hypertrophic cardiomyopathy, in this patient population, growth hormone appears to be safe in these children. The available data review did not demonstrate any exacerbation of cardiac pathology, a worsening of glucose metabolism, or increased risk for cancer. So, those are the 8 current indications for growth hormone treatment in children. So I added this slide because I think that once we already know indications, so we should know contraindications as well. So growth hormone is contraindicated in patients with closed epiphysis. This is for pediatric patients and patients with active malignancy, patients with acute critical illness, Prader-Willi syndrome patients who have one or more of the following risk factors: severe obesity, history of respiratory impairment or sleep apnea, or those with unidentified respiratory infection, and patients with severe secondary hyperparathyroidism also contraindicated for growth hormone use, and diabetic patients who have severe diabetic retinopathy also. So this slide just to capture, the 8 indications that I have presented. So if you have patients with these conditions in your practice, or maybe in your practice in the future, so you may consider appropriate referral for possible growth hormone treatment. And this is the references that I have used, for the presentation today. Thank you for listening.
Thank you, Dr. Umpachitra. So I welcome Dr. Bargman. She graduated from SUNY Downstate with an MD in 2003 and completed her residency in pediatrics at the New York Presbyterian Hospital, Weill Cornell Medical Center in 2006, and her pediatric endocrinology fellowship at the same institution in 2009. She is board certified in both pediatrics and pediatric endocrinology. Dr. Bargman has been the director of the Pediatric Endocrinology Division at Nassau University Medical Center from 2009 to 2017. And now she works as a pediatric endocrinologist at Coney Island Hospital, Kings County Hospital, and SUNY Downstate. And she is a clinical assistant professor at our center. Dr. Bargman will be presenting past, current, and emerging growth hormone formulations.
Thank you very much, Dr. Chin, and big thank you to Dr. Rappaport and Dr. Umpachitra for their wonderful presentation from earlier. Let me start sharing my screen. So we're going to talk a little bit about long-acting growth hormone preparations, what has been in the past, what is happening right now, and some future directions as well. The objectives of this talk are to increase awareness of the emerging science of long-acting growth hormones, to improve the understanding of their efficacy, safety, and potential clinical applicability. I have no conflict of interest. I will use some brand names. Some of these new things that are coming to the market have similar names, so it's important to think about both the brand name and the generic name for these products, so as not to be confused. It's sort of a little bit of a confusing landscape, especially since it's so new. So as we have talked about at length thus far, both Dr. Umpachitra and Dr. Rappaport, there are a number of different indications for growth hormone. The most obviously understood one is growth hormone deficiency. And then there are all the other indications, idiopathic short stature being the most difficult to get approved by insurance and the most ethically controversial. So we have known that there are some people who fail to grow for a very, very long time. And people known as dwarfs have been interesting to the public for a very long time. The two kinds of dwarfism that were most commonly seen were achondroplasia, where you have disproportionate short stature, and growth hormone deficiency. So this is somebody who was in the one of the curiosities in the Barnum circus. His name was Charles Sherwood Stratton, and he was known as General Tum Thump. He was very, very short. This is him as a child. His parents kind of sold him to the circus as a child. You can see him together with P.J. Barnum. And you can see him as an adult and as at his wedding, where he was married to a woman who I believe may have had achondroplasia. I don't think that she has growth hormone deficiency. The way you know that is if you look at her face and her head, she seems to have a bit of more disproportion than Charles Sherwood Stratton. But for a very, very long time, we did not know why it is that there are some people who fail to grow. Growth hormone as a molecule was discovered relatively late, and we were only able to synthesize it in 1970. Dr. Lee is the one who's credited with the purification and synthesis of growth hormone that we know today. It came about significantly after our ability to produce other hormones such as insulin or cortisol. You know, hydrocortisone came about a bit significantly earlier. The National Pituitary Agency was founded in 1960 and was responsible for growth hormone therapy in the United States until 1985. All of this therapy was human-derived growth hormone, cadaveric growth hormone, and all in all, about 7,700 children in the United States and 27,000 children worldwide were given growth hormone that was extracted from human pituitary. And as sort of a proof of concept, it worked very well. This was the time when the cutoff for growth hormone was 5 nanograms per milliliter because there was a very limited supply of growth hormone. So the agency wanted to make sure that only people who were most severely affected would be getting this treatment. People who had mild growth hormone deficiency, people with other indications were not considered for this kind of growth hormone therapy. In the 80s, it was understood that some of the people who received this treatment developed Creutzfeldt-Jakob disease, a prion disease that must have come from some of these cadaveric pituitaries or had the prions in the mixture. So there were some people who were inadvertently infected with Creutzfeldt-Jakob disease. 27 patients developed it, and the program was shut down in 1985. There was a little bit of a break when people could not get growth hormone, but luckily, soon after, human recombinant growth hormone came on the market. So the recombinant growth hormone technology, the idea here is that you have a human cell and you have a bacterial cell. In the bacterial cell, there's the plasmid that has the bacterial, there's the bacterial chromosomes. The gene for growth hormone is extracted from the human cell. And with recombination, that's why it's recombinant growth hormone therapy, it is inserted into the plasmid of a bacterial cell, so that now you have a bacteria with a plasmid that is carrying the gene for growth hormone. And now this bacterial cell is going to be making growth hormone, human growth hormone coming from the bacteria that can be isolated. You no longer have the problem of contamination or anything like that, because this is something that is done in a factory. People are not involved. There isn't really any kind of, you can have regular contamination the same way that you would with any other liquid, but you don't need to worry about this being infectious or anything like that, because it's just a bacterial cell making this human growth hormone. This was the founding of the first true biotech company, which was Genentech. These are the three people who filed for patent for this technology in 1980. So just around the time when the Human Pituitary Agency was shutting down, this new technology was coming on the market, and it was going to become the future of growth hormone, as well as many other therapies that we currently use today. Right now, the biotech market is a very large one. There are all sorts of different players. This is from, I think, about a year ago. You can see the Genentech, the first biotech company, the first maker of recombinant growth hormone, is still very much on the market, but there are all of these other different companies that are playing a game. Some of them also make growth hormones. So a lot of the different companies make growth hormones. So Novo Nordisk, for example, Lilly makes growth hormone. There's some others here who did not make it into the slide. They don't make a big enough part of this pie chart. So this is how growth hormone is currently made. It's actually in a big factory. There's a factory, I think, somewhere in near San Francisco. One time I went to San Francisco, I was offered to go and see it. Unfortunately, I didn't get to, and I'm very much regretting. Hopefully next time that I go to San Francisco, I can go and see how growth hormone is physically manufactured. Would be really a great kick to see that. So there are different daily growth hormone preparations. They basically all have the same recombinant growth hormone. Some of them, they have slightly different official indications. All of them are indicated for replacement of growth hormone and growth hormone deficiency, but some of them also have an indication for Turner's, and some of them will have an indication of Prader-Willi, or any of the other indications. Generally, people use them interchangeably. It is very rare that somebody will say, well, you know, this particular formulation is not indicated for, SGA, and so therefore I'm trying to use a different formulation. These are all bioequivalent growth hormones. The biggest difference in the different formulations is the method of delivery. So some of them are very simple. These kind of growth hormone pens, the growth hormone pens are exactly like insulin pens. Over here, you have the little dial. You dial the amount of growth hormone that you're going to be injecting. There's a little pen needle that gets put at the tip, and you inject the growth hormone as you need it. There are some more complicated devices, some that require mixing. Some of them come pre-mixed, some of them have to be mixed. So this is something that requires mixing. It's called Click Easy. It's not that easy, but if you happen to have insurance that happens to cover Sizen, then chances are you're going to figure out how to use this Click Easy. There's this interesting device called the EasyPod, I think. EasyPod is also made by Sizen. You put in the growth hormone into this device. It dial the amount of growth hormone, and it will inject. You put it to the skin, you put this part to the skin with a little needle, and it's going to inject. You press a little button. The nice thing about a device like that is that you don't really see the needle quite as much, and you can also have a calendar, and the doctor could review whether you're truly taking your growth hormone or not. It's going to tell you how many days in a week the patient took their growth hormone. There are some other devices. This is a device that is needle-free. It's called the T-Jet. It injects the growth hormone with a strong puff of air. In theory, this is targeted to people who are needle phobic and they don't want to, see a needle or anything like that. In my personal experience, it hurts way more than a needle. I would not opt for this if this was my choice, but there are some people for whom sort of the psychological absence of a needle is very, very key. Adverse events associated with growth hormone, both Dr. Umpa and Dr. Rappaport have spoken about this. There are some pseudotumor cerebri, edema and SCFE, which are more theoretical than real. I have seen worsening of scoliosis once in a patient where it really affected their eventual outcome. And then there are the theoretical worries, such as increased risk of malignancy. This is especially concerning in people who are survivors of cancer. They have an increased risk of secondary malignancy anyways. So if you give them growth hormone, you increase the risk. And the idea of whether you will have increased all-cause mortality. So whenever we talk about adverse side effects of growth hormone, long-term side effects, we have to remember that most people who are receiving growth hormone, who received growth hormone in the past, have not really lived long enough to know whether there's truly not going to be these long-term side effects, right? So the recombinant growth hormone came on the market in the early 90s. So the oldest people who got growth hormone on a mass kind of scale would be people who are currently in their 40s, right? So you always have this consideration in the back of your mind, especially when you're treating people who are not otherwise ill, not people with growth hormone deficiency, but idiopathic short stature, where you just have much more of just a height alone worry. You need to consider whether, this could be somebody who has an increased chance of malignancy in their 60s or 70s. It may very well be that this is the case, and we just don't happen to know that. Thus far, the studies in healthy people who receive growth hormone do not seem to have any kind of indication that you have increased malignancy or increased all-cause mortality. There were some studies that were published about 10 years ago. There were two different studies. One came from France and one came from the rest of Europe without France, that showed that there is perhaps a little bit of an increase in mortality, especially with higher growth hormone doses. So this is coming from France. With a higher growth hormone dose per day, you seem to have an increased all-cause mortality. With the smaller doses, you do not seem to have that increase. If you look at the confidence intervals here at the dose of 50 micrograms per kilo per day, you have, it seems that the confidence interval is very much suspicious of increased mortality for people treated with growth hormone. We usually treat people with smaller doses than that. In the US, at least, we calculate the doses as milligrams per kilogram per week. So we start at somewhere around 17 milligrams per kilogram per week for growth hormone deficient patients. So that would be about 20 micrograms per kilogram per day. And usually we get somewhere into this range, 30 to 50 micrograms per kilogram per day. It's uncommon to get into these higher ranges, although there is some literature looking at these kind of doses in children with Turner syndrome and pubertal children. So something to kind of think about. The different conditions that these people had, unclear, so for example, here, the increased mortality for increased risk for infectious and parasitic diseases. Why would exposure to growth hormone increase your risk for infectious and parasitic diseases? Not sure I could tell you. Endocrine, nutritional, and metabolic diseases, here you have a little bit more of a suspicion. Perhaps growth hormone is a counter to insulin hormone, right? So it decreases your insulin sensitivity. Perhaps here they're talking about an increased risk of diabetes or something like that, something to keep in mind. And here is the other study looking at the other countries, not at France, but Belgium, Netherlands, and Sweden, which did not show an increased risk in increased all-dose mortality. They looked at the different premature sort of reasons for death in these patients. Hard to imagine how a traffic accident or homicide or, all of this kind of things would be correlated with growth hormone use. You would think that this has something, that this is probably just an unlucky accident. And we still don't know whether this kind of use of recombinant growth hormone in childhood increases any kind of risks of subsequent adverse events, but something to keep in mind. So we talked a little bit about idiopathic short stature. Idiopathic short stature is something that is very difficult to get insurance coverage for, especially when you live in a state that doesn't cover idiopathic short stature. In New York State, there is a law that was passed by Albany to not allow Medicaid to cover idiopathic short stature, and this is because of the cost. So whenever we think about any kind of interventions that we're doing to a lot of people in the society, we have to think about the cost of this. For a child with idiopathic short stature, it costs about $55,000 to grow an extra inch. So is it worth it for us as a society to be doing something like that? Get these kids to be a little bit shorter, who are shorter, to get them to be a little bit taller, something that can very much be up for an ethical debate. There are people who will argue yes, and there are people who will argue no, and all of those people have very solid arguments behind them. So let's talk about long-acting therapy. So in endocrinology, we love to play with different ways of giving medications, right? So one thing that everybody is well familiar with is the different duration of action of different insulins, right? So whenever anybody is a resident and they start to have a patient on the floor with diabetes, they are prone to have this problem where they confuse one insulin for another, and they order the wrong one because they sort of, they all have similar names, and it's easy to confuse them, and the NPH and the regular and all of this type of stuff. All of the insulins, the way that their duration of action is dependent on they're all recombinant growth, recombinant insulins that have different molecules fused to them, and that's what determines how fast they go into the circulation, so that how fast from their duration of onset and how long their duration of action. We have all sorts of different insulins. Some of them are rapid acting, right? You guys know this, where their onset of action is 15 minutes and they can last for about 3-4 hours. And the longest ones, they can last a day or longer. There are some not on this chart. They can actually be maybe a day or so. There are some insulins in production now that may be as long as a week. Some basal insulins that we are going to be very excited to use once they come on the market. And then there are all sorts of other preparations that we use that have much longer duration of action. So we're all familiar with weekly GLP-1 agonists, right? Things like Ozempic and Trulicity, Bydureon, a thing that gets injected just once a week. And that's very easy for the patient. Well, not that easy, but at least much easier than injecting something once or twice a day, right? So we tend to be very enthusiastic about long duration of action treatment for chronic illness. There are other ways. It doesn't have to be an injection. Birth control patches, for example, they get put on and they will stay on for a week, so that a person can forget about them. You don't have to worry whether they took their pills every day. This works by a different mechanism, where you have an adhesive and you have a slowly releasing medicine coming from the different parts of this patch, right? So you could see why we would be interested in doing something like this for growth hormone, right? You have children don't like shots, so doing as few shots as possible is something that is theoretically very enticing. So what are the potential benefits of long-acting growth hormone? Well, kind of obvious, right? They would improve adherence, decrease the burden, allow for longer treatment. People tend to get very excited when they start growth hormone, and then their enthusiasm may wane as time goes on, so that they may not end up doing their entire course of treatment, something that in theory seems to make much sense. Kids and needles, not a great combination. How much of a problem is this? Is this a theoretical concern? Is this a real concern? So this was a meta-analysis of different studies that were looking at publications that looked at children and their ability to carry out their growth hormone therapy as prescribed. So mean adherence. If you look at the different studies, you can do the studies differently. You can look at pharmacy fill, so you find out whether they actually got their medicine from the pharmacy. Self-report, which is of course the least, everybody says that they always take their medicine. You can see the difference here between the self-report ones and the pharmacy fills, right? You're going to see that you're going to see fewer pharmacy fills than you do with self-report. And you can look at the device. Most of these devices don't have a way to know whether you truly took your growth hormone. If you use something like the EasyPod, then you can have an idea of whether the patient is really adherent based on review of the device, similar to the way that we review insulin pumps. So overall, if you look at it, the adherence is, and the mean adherence is not bad. Somewhere definitely above 50%. Somewhere in probably the 80s would be the average, with the pharmacy fill study showing the least adherence. Median adherence. So this is the difference when you think about your statistics, the difference between the mean and the median. So the mean is less than the median, right? So that means that there are some people who are really not adherent and they're dragging down the average. Most people are adherent, so the median is higher than the mean, right? Most people are pretty adherent. And even if you look at the pharmacy fill, most people are doing okay. And there are some people who are very not adherent. They're dragging down the whole group on the average. So percentage of adherence patient, how many of them are adherent? And you start to see that, especially in this study. Here you have 50% of the patients who are not entirely adherent, right? And it probably very much matters which population you're looking at. Same as insulin adherence, any other kind of medicine, people who are, there are some people who really have problems adhering to these kind of therapies. What are the barriers? They kind of make sense, right? The older age in adolescents, when they started their growth hormone therapy, when they were 8 or 9, they were excited, and now they're 14, 15, and they sort of have had enough of you and your needles and all of this type of nonsense, right? Low family education engagement, you need the family to be supportive. Lower education level of the mother, same kind of thing. The longer duration, treatment duration. If the patient is the one who's administering medications, we all know how teenagers are not the most reliable people on this planet. The device design, something that is difficult to mix, where you kind of have a lot of steps, you have a lot of ways to screw up, and the higher number of doses per week. So what can we do? We can do all sorts of things that we normally do to try to improve adherence, right? And so one of the things that we can think about is this device design and decreasing the number of doses per week. There was a long-acting growth hormone product that was actually on the market since the very beginning. So in the 1990s, there was Utropine depot was made. It was growth hormone that was encapsulated in microspheres composed of this polylactide co-glycolide that was fully biodegradable. This was a weekly formulation. It was not terribly successful. The reason why it was not successful was that you needed to use a large volume. It was a very viscous medication with a large bore needle that left a lump under the skin. I have spoken to some adults who had this Utropine depot as children. They do not have fond memories of Utropine depot. It seems like the injection was similar to the Lupron injection, which is rather painful. So they, and while the normal growth hormone, the daily growth hormone, is a pretty painless injection with most formulations, this did not really help with improving patient adherence. And this product was taken off the market in 2004. So currently, there are all sorts of different products that are around that are being considered for, they're in different sort of studies. Some of the studies have gone out of favor, there's some of the studies are still ongoing, and there are some products that have been approved. So there's this Utropine depot that we talked about. It was actually a 14-day formulation. It has been removed from the market. There is a formulation that is approved in Korea, a once every 7-day formulation. called Utropine. Interesting, Utropine is not approved in Europe. You would think that if you name your thing Utropine, you're expecting that it's going to be approved in Europe. Actually, it is, I'm sorry. It's approved in Europe, but it is not marketed in the EU. So I think their whole, you know, the naming, the brilliant naming hasn't quite worked out for them as planned. I'm not going to talk too much about these because they don't seem to be coming to the American market. I'm going to leave them to the side. There is another product that has been approved, marketed in China called Gentralong, also a 7-day formulation. There are some studies that are going on, phase 4 studies ongoing. Perhaps this product will also be eventually tried in the United States and in Europe. So far, it hasn't been. I also did not look into this one too much. The ones that we're going to concentrate on are TransCon growth hormone, which has been approved in the US under the brand name of Skytropha. This is the only one that is currently approved for children in the United States as a 7-day formulation. And this drug is marketed by the company called Ascendis. There is another formulation by Novo Nordisk called Sagroya. This one has been approved for adults. There are currently phase 3 studies going on in children, but it has not been submitted to the FDA for approval just yet. And there is another formulation by Pfizer and Apco Health called Somatrogan, and this one is sort of a strange one. It has been approved in Europe. It has been denied FDA approval. Why it has been denied FDA approval is not terribly clear to me. We will go through some of their data. Their data looks pretty decent, and the FDA did not really issue a detailed statement, which is sort of a very, very vague statement. I wonder if anybody in the audience perhaps has some kind of inside knowledge about why this product was not approved by the FDA. So the one that has been approved. So this product called Skytropha, also known, so it's TransCon growth hormone. That was its initial generic name, and then it had been renamed into, just to make everybody's life very complicated, Lona Peg Subtropin. And it's because it is a PEG fused growth hormone. So this is a very new technology. This is the very first product on the market using this technology overall. The idea here is that you have this TransCon carrier that surrounds, and there's a linker, and then there is human growth hormone that isn't modified at all. So one of their big sort of claim to fame is that in addition to having this long-acting growth hormone, the growth hormone is entirely human growth hormone. It is not at all modified. So when this product is injected, the carrier slowly degrades and gets cleared by the kidneys, and the growth hormone, unmodified human growth hormone, gets slowly released, and then it goes and gets picked up by its receptor, and all the pathway that growth hormone normally goes through, it will follow. This company has a few other medicines going through trials at the moment. So it has a CNP for the treatment of achondroplasia, which is going through phase 3 clinical trials, where they would have an injection of CNP for achondroplasia that would also be given weekly. The vosoritide, which has been brought up by the previous speakers, is a daily injection of CNP that has been modified. They also have a product for treatment of hypoparathyroidism, a PTH, with a similar marker where you could also inject it once weekly. I believe that one, I think, is a little bit further in development, and that one is not being looked at for pediatric indications, for adult indications to replace the previous PTH injection that has been taken off the market. So this is a look at their phase 3 study for Skytropha. It was a 2-to-1 design to patients got Skytropha for anyone who got daily growth hormone. So they received either this, I'm going to call it Skytropha. I'm not going to try to keep on pronouncing this every time. I can also call it TransCon growth hormone, but this whole thing is completely unpronounceable. So they were getting either this or daily growth hormone, both of them dosed at 0.24 milligrams per kilogram per week. If you guys remember, normally growth hormone is dosed somewhere around there. We started around 0.17 milligrams per kilogram per week, and we can go up, and people usually go up to about 0.4 milligrams per kilogram per week, depending on the response. So this is their subgroup analysis of annualized height velocity with the confidence intervals. As you can see, it seems that for the overall group, there was some favoring of TransCon growth hormone. They seem, and this is looking at annualized height velocity. So it appears the people who got this weekly growth hormone did a little bit better than people who were getting daily growth hormone, right? So this was a trial that was designed to prove non-inferiority, but in fact seems to show some superiority. And this is especially significant for children under 6. It didn't so much matter what their baseline growth hormone was, their stimulated growth hormone, males, females, and what the reason for their growth hormone deficiency was. If you look at it for as a graph, you can see that the height standard deviations change from baseline. Both daily growth hormone and the weekly TransCon growth hormone had people much improve in their growth, right? And the weekly growth hormone did a little bit better, and this was indeed statistically significant. You don't see overlap of their standard deviations. One thing that you worry about with a weekly formulation is whether you're going to have big variations in IGF-1 levels. So as the previous speakers have pointed out, you want the IGF levels to be normal. You don't want them to be low, but you also don't want them to be high. There is a consideration that perhaps high IGF-1 levels will increase your subsequent risk of malignancy. So you don't really want to see IGF-1 levels that are above 2 standard deviations above the norm. Something that gets injected once a week makes sense that they would have sort of higher peak levels and lower trough levels than a medication that is injected daily. So if you look at this, it looks like for the majority of patients, right, they did not really go to above 2 standard deviations. And there was a bit of an oscillation. Here's 0, right? So you do oscillate a little bit as the weeks go on. But that's just looking at the weeks, right? But let's look at the days. You know, I'm sorry. Let's look at you know, this. You want them to ideally be in the 0 to 2 standard deviations of IGF-1, right? And after at baseline, since these are growth hormone deficient patients, their IGF-1s are low, makes sense. And then as they get treated, their IGF-1s are going up. It looks like the IGF-1s of the weekly medicine are higher than those of the daily medicine, but there seems to be a lot of overlap, and this is not statistically significant. And if you look at the splatter graph, you see that there are some patients whose IGF-1s are pretty high, right? Most of them are not, most of them are acceptable, about 1 standard deviation, okay, but there are some whose IGF-1 levels are pretty high, something to consider when you're treating them with this formulation. So let's talk about the other medication that is not on the market for pediatrics. It is approved for adults with growth hormone deficiency with a weekly injection. So this is a growth hormone that has a human albumin binding moiety, and that's what creates its long-term, that's how it is not it doesn't infuse immediately. It sort of has its weekly time scale. This is the design of the current phase 3 trial. This is the design of the trial. So this was a phase 2 trial that went into the phase 3 trial. The phase 2 trial looked at a much smaller number of children, also with growth hormone deficiency, looking at different doses of this medication. The medication's generic name is somapacitan, compared to growth hormone with daily growth hormone. The daily dose of growth hormone was 0.034 milligrams per kilogram per day. And the dose of somapacitan was, as you can see here, with the biggest dose being 0.16 milligram per kilogram per week. This dose of 0.034 milligrams per kilogram per day is equivalent to 0.24 milligrams per kilogram per week. So the dose of somapacitan is a little bit less than the dose of the daily growth hormone. It was initially seen that the 0.16, the higher dose, appeared to be safe. And so the phase 3 trial is looking at 0.16 milligram per kilogram per week. So there were 86 patients that were initially included in all of these different arms. If you look at the data, annualized growth velocity, so depending on the dose, there was different growth velocities. The best was seen with the 0.16 milligram per kilogram per week, and this is compared to the light blue, which is the daily growth hormone. If you look at the mean height velocity at baseline, week 26 and week 52, again, you can see that 0.16 milligram per kilogram per week was doing better than all the other doses, and it were pretty equivalent to 0.34 milligrams per kilogram per day. The mean height velocity standard deviation, again, the same basic thing. You can see that, depending on the dose, you can you get different height velocity with these. There seems to be the 0.16 milligram per kilogram per week is a little bit better than the daily growth hormone, although it's not clear it crosses zero. It's not clear whether this is truly superior or just not inferior. And they modeled IGF-1 fluctuations over a week. So you can see that you have this problem of the peak and the trough. So for daily growth hormone, the IGF-1 is pretty stable throughout the week. For the different somapacitan doses, you can see a little bit more variation, especially for the higher dose, but it doesn't really go above 2 standard deviations, and it doesn't go below -2 standard deviations. So perhaps it seems to be good enough. The observed IGF-1 peaks and troughs. So for the different doses, here we worry about this higher peak, right, of the 0.16 milligram per kilogram per week. You see that it doesn't seem to be going above 2 standard deviations, but there is a pretty big standard deviation. You have to remember that this is a pretty small study, so there are not that many patients, so you don't have tight standard deviation intervals. They also looked at emotional well-being. Kind of interesting that people who were on the higher dose of somapacitan, none of this is statistically significant, but still, people on higher dose of somapacitan seem to show better emotional well-being. People on the lower doses seem to show decreased well-being. I don't know if the problem could be that they see that they're not growing quite as fast as they would be otherwise, and perhaps that's why they're upset. None of this is statistically significant, so you can't really make too much out of it. And finally, the third long-acting growth hormone. This one is called somatrogon, and it's a completely unpronounceable brand name. is Genla. How they came up with that name, I cannot tell you. This is the one that has not gotten FDA approval in the US. It has been approved in Canada and in Japan. This paper has not yet been published. I'm getting these slides from the presentation of the 2020 Endocrine Society by Dr. Deal that were available online so that we could review the study and maybe try to figure out why this medication was not approved. So again, this is the growth hormone, and it is bound to the CTP molecule, and that is what's responsible for its delayed release. This was a one-to-one randomization design of somatrogon at a higher dose, 0.66 milligram per kilogram per week, compared with genotropin as a daily growth hormone. And then there was a long-term open label extension until market approval. This is their table 1. It seems to be kind of all okay. There's the usual breakdown. There's peak growth hormone is less than 3, more than 3 to 7, 7 to 10, makes sense. This is the primary endpoint, margin of non-inferiority, right? So they did not show superiority, but they did seem to show non-inferiority compared with daily growth hormone injections. The secondary change in high standard deviation from baseline again showed these standard deviations overlap. So so you can't say that it was superior, but it doesn't seem to have been inferior. And if you look at the different groups, the ages and all of that, all of it seems to cross midline, cross 0. So it does not seem to be superior. It does not seem to be inferior. It seems to be sort of just fine. Side effects, there do not seem to have been a huge amount of side effects in the study. Most of them seem to be mild. There was one study adverse event leading to withdrawal from the study. I don't know what that adverse event was. If this was the thing that tripped the FDA, it was not in these slides. And as I told you, this is not a paper that is yet published. And finally, the IGF-1s that we always worry about. So you can see, hold on, let me go back. Where do I go back? Well, never mind. The IGF-1 plot, scatter plots were very, very similar to the ones that we saw for the other products. I really don't understand why this one was not approved by the FDA. It could be that they had a slightly smaller trial. The other one was a 2-to-1 trial, so they had more patients. It could be that the side effects tripped them. It could be that the fact that the IGF-1s were in the higher, a little bit sort of like there were some people whose IGF-1s were above 2 standard deviations. I'm not quite sure why this particular one was not approved. The company issued a statement saying that they see a great future for it, and they're going to continue to work with the FDA to get this product approved. So anyways, in summary, recombinant growth hormone, we have used it for 30 years. There are new long-acting growth hormone formulations being approved. One is newly on the market. This new one, the one that's just come on the market, has been approved somewhere around November of last year. I don't know if any of the participants of the conference have tried using it already. I had one patient in whom I tried to get it because it's a boy who sort of doesn't like to take his growth hormone daily. His growth velocity is suboptimal. He has growth hormone deficiency. He really wanted a weekly formulation. So far, I'm fighting with the insurance, and I'm not having great luck in having it approved. One has to assume that this weekly formulation is going to be significantly more expensive than the daily formulation. As we all know, growth hormone companies don't love to approve daily growth hormone. I bet they're not going to be too thrilled about approving something that is probably going to cost twice as much. So we will see where this becomes, whether this becomes truly useful, whether this is something that ends up replacing daily growth hormone as the years go on, or it will become sort of a niche thing like the Utropine that will eventually prove not to be terribly useful.
Thank you, Dr. Bardman.
Any questions?
I can read some questions on the chat while people think of questions. Someone's comment says TJET has been discontinued.
Oh, good. I hated TJET.
Another question are, how are the human cells obtained and from where that are used for the production of growth hormone?
Oh, there are no cells. It's just a gene. So the initial, in the beginning, they had human cells where the gene was extracted from, but that was a very long time ago. You know, since then, they just have the gene.
Right. Next question. So overall, would you recommend administration of long-acting growth hormone for children? And can you switch between the long and short-acting formulation?
So it's a new thing on the market, right? Whenever you have any kind of new medicine on the market, you always have a worry that it's going to have something unexpected, that it's going to have unexpected complications that were not picked up in the study. And we have daily growth hormone. Daily growth hormone works pretty well, right? So I would say that in a patient where adherence is a major concern, where you really think that weekly growth hormone is going to improve how much growth hormone they're actually taking, I would consider. In somebody who's doing great on daily growth hormone, I'm not sure that I would necessarily do that. And as far as switching, my assumption is that most insurances are going to require that you try and fail daily growth hormone before you get this one. You know, unless you can have some sort of very impressive reason why you need to go straight to the weekly growth hormone, unless, you know, there's going to be insurance companies that decide that this is their preferred formulary agent. Given that I think it is significantly more expensive, I can't imagine that there's going to be many growth hormone, many insurance companies that do that.
Does anyone else have any questions? Thank you, Dr. Bardman.
Thank you.
Okay, I think we have 5 minutes before we start at 12:05. So if everyone can take a rest, we'll resume in 5 minutes. Hello, welcome back. How are you all? All right, so our last speaker is Dr. Jacobson Dickman. She is an associate professor of clinical pediatrics and the associate dean for clinical medicine at SUNY Downstate Health Sciences Center University, where she oversees the core clinical and advanced clinical medicine years for the integrated pathways curriculum. Dr. Jacobson Dickman obtained her Bachelor's of Science degree from McGill University in Montreal, Canada, and her medical degree from Albert Einstein College of Medicine in the Bronx. After completing a pediatric residency at Children's Hospital at Montefiore and a pediatric endocrinology fellowship at Harvard Medical School, Massachusetts General Hospital, she joined both SUNY Downstate and Maimonides, where she ultimately became the Pediatric Endocrinology Fellowship Program Director. At Maimonides, she also served as a hospital-wide Director of Faculty Development. While she cares for children with a wide range of endocrine disorders, Dr. Jacobson Dickman has a long-standing interest in puberty, reproductive endocrinology, and she has published research in these fields and is a co-director of the College of Medicine's first-year reproductive endocrinology course. Dr. Jacobson Dickman will be presenting Short Stature, a case-based approach.
Thank you so much, Dr. Chin. Could everybody hear me well? Okay, fabulous. That was a very nice introduction, and what you may not have heard was any particular expertise in growth, but certainly now that I'm a few decades out of my fellowship, I have seen some very, very interesting cases. Before I begin today, my lecture on short stature, a case-based approach, I would like to just say that I have no conflicts of interest to declare. So this session is really designed for interactivity and active thinking and clinical application. So please do join me in this active thought process and either write in the chat or unmute yourself. And if you'd like to respond to any questions I sort of throw out there, please do. And being that this is noontime, I believe we may have a crowd, I hope, that has some concentration of pediatric residents and fellows and even students. And I would like to encourage that group to really take front stage to the degree that you're comfortable. And for those tuning in now, I am going to do a little bit of a brief review that might, I hope won't be too repetitious, of the growth hormone IGF-1 axis. And then I'm going to discuss some normal growth patterns, including intrauterine versus postnatal growth patterns, a basic clinical reasoning and diagnostic approach to incorporating growth data as an integrated measure of health in childhood. And finally, I'm going to present some details from cases, either my own or those I had some kind of involvement in. And I hope this will demonstrate at least a few pearls each in the diagnostic and therapeutic approaches to children presenting with short stature. Wonderful. So let's begin with growth hormone IGF-1 axis physiology. Okay. So growth hormone, as I'm sure you know, is synthesized in the anterior pituitary, where it's stored in secretory granules. It's the most abundant hormone in the pituitary gland that's accounting for 25% of the gland's hormone. The tissue-specific development of somatotropes and expression of growth hormone appear to be largely determined by the PIT1 transcription factors. And several factors, including hormones, transmitters, and metabolic modulators, are known to regulate growth hormone. So growth hormone secretion is directly controlled by the hypothalamus and peripheral factors acting on somatotropes, as I said. And hypothalamic growth hormone releasing hormone stimulates growth hormone synthesis by increasing both the growth hormone gene transcription and its release. Growth hormone receptor hormone will bind to its specific receptor, the GHRH receptor, and that's how it functions. And that may become relevant, a little foreshadowing later in our talk. Somatostatin, or somatotropin releasing inhibitory factors, as the names may suggest, inhibits growth hormone secretion. It inhibits its release, but not its synthesis, unlike GHRH. Ghrelin, a 28 amino acid hunger stimulating peptide, is also an important stimulant. It is the endogenous ligand, actually, for growth hormone secretagogue receptor. Ghrelin regulates growth hormone release in a dose-dependent manner. Insulin-induced hypoglycemia exerts additive effects to growth hormone release. Okay, glucose has an inhibitory effect on growth hormone, and we use that knowledge clinically. A growth hormone spontaneous nocturnal secretion is low, both in hypothyroidism and hyperthyroidism. And the negative effects of glucocorticoids on growth are very well known. And of course, serum growth hormone concentrations rise throughout puberty in both sexes, in healthy males and females under the influence of sex steroids. And lastly, a number of other stimulants exist, primarily at the level of the hypothalamus And those include dopamine, high protein meals, and metencephalins, which are sometimes referred to as opioid growth factors, and they are naturally occurring or endogenous opioid peptides. Okay, so we know all the regulators. This is very important to keep in mind when we see our patients. But now we have to ask ourselves, what does growth hormone even do, right? What's its predominant action? And the predominant action of growth hormone is actually to stimulate hepatic synthesis of secretion of IGF-1. It sort of got the big name, but most of the work is really done by IGF-1 because that's the potent growth and differentiation factor. And so then our question is, what do IGF-1s do? Okay. And as I said, it's the differentiation and growth factor that's really likely responsible for most of the growth promoting activities of growth hormone itself. So growth hormone acts, I'll get to this part, by binding to specific receptors, a homodimer, which is located mostly in the liver. It induces intracellular signaling by a phosphorylation cascade that Dr. Rappaport referred to earlier, and this involves the JAK and STAT pathway. And this will stimulate IGF-1. So IGF-1 is a small peptide. It circulates in the serum bound to high affinity binding proteins. It's unusual because most of it, actually 99% of IGF-1 that circulates is bound. And it circulates in this ternary complex with acid label subunit, ALS, and IGF-BP3. And as Dr. Rappaport discussed earlier, those are also deficiencies for various reasons are associated with growth hormone failure to, or IGF-1 failure to promote growth. So as I said, it circulates as a ternary complex with ALS and IGF-BP3, and those are also actually regulated by growth hormone gene products. So in this trio, it primarily circulates and stimulates the receptor at the level primarily of bone and muscle. Now, and this stimulates growth, of course. To a smaller degree, growth hormone does have a direct effect on bone. And there is also notable autocrine and paracrine IGF-1 effects that are synthesized in peripheral tissue, such as the bone as well. So now what happens if growth hormone doesn't get to work? Okay. For example, what happens if the growth hormone receptor does not work? We're going to have, of course, low IGF-1. And what does that result in? That's going to result in growth hormone insensitivity. Okay, so growth hormone insensitivity is a group of inherited disorders in which there is reduction or absence of the biological effects of growth hormone, despite normal production of growth hormone or even elevated production. These disorders, as you may suspect, are characterized by growth failure and normal or even high levels of growth hormone. And this is in direct contrast, of course, to growth hormone deficiency syndromes. So the classic model, which I'm going to discuss and was also mentioned earlier, is Larone syndrome. Okay, and these are caused by the example I gave earlier, mutations in growth hormone receptor. Okay, they are characterized by severe postnatal failure, and I stress postnatal failure, and we'll talk about why later. It's caused by homozygous or either compound heterozygous mutations in growth hormone receptor gene. Patients have severe growth failure with a mean adult height in one report of 119 centimeters in women or females and 124 centimeters in males. But there is wide variability, I should mention. Other clinical features of Larone syndrome include postnatal growth failure, characteristic facies with depressed nasal bridge, prominent forehead, truncal obesity, and they may also have metabolic abnormalities, including hyperlipidemia, episodes of hypoglycemia, particularly during infancy, And data are sort of conflicting about the insulin resistance. So historically, these individuals were considered at risk of obesity and insulin resistance. And if untreated with IGF-1, okay. However, in a later report, patients with Larone syndrome had substantially less insulin resistance and lower rates of diabetes than their relatives who didn't have Larone, despite having higher percentage of fat. So I think the jury is still out a little bit. Interestingly, though, individuals with Larone syndrome appear to have much lower cancer rates. And this was in comparison to healthy controls. So experimental evidence from animals and in vitro studies are suggesting that low levels of IGF-1 in Larone syndrome are responsible perhaps for reduced susceptibility to cancer and for increased longevity. And of course, these kinds of discoveries are of great interest in the scheme of cancer research. So as mentioned, the classic model of growth hormone deficiency, insensitivity is in patients with Larone syndrome caused by these growth hormone receptor gene mutations. But subsequently, it's been shown that there's a spectrum of growth hormone insensitivity caused by a variety of defects along the growth hormone insulin-like growth factor 1 axis, as you can see. Now, defects of growth hormone action have expanded the understanding of the growth hormone IGF-1 axis physiology and the spectrum, of course, of growth hormone insensitivity syndromes. And a growing body of literature suggests that some patients with ISS, idiopathic short stature, often have a component of growth hormone resistance as well. And this may call for alternative approaches, such as adjusting growth hormone doses based on IGF-1 levels. As you notice, it's expected that individuals with growth hormone deficiency or growth hormone deficiency-like syndromes are expected to be quite sensitive to exogenous recombinant growth hormone. So now let's pivot a little bit about growth parameters and contrast intrauterine compared to intrauterine compared to postnatal growth. Pardon me for a moment. So a mentor of mine many years ago, Dr. Paul Bopel, who's one of my finest teachers, who I emulate to this day, he used to give this example, which I hope he won't mind if I borrow, and asked the crowd, what if we, quote unquote, married this male large horse breed called the Shire to this Shetland pony, the small horse breed. And at this point, the group of learners would always respond somewhere in between. And this opens the door, of course, to more learning. So indeed, what we learn from the size of babies who are born with anencephaly, the missing of the development of the brain, who are unable to secrete growth hormone, is that fetal growth hormone is likely responsible for only 20% of somatic growth, whereas the more important contribution appears to come from the uterine environment, such as the birthing person's size, nutrition, stress, blood supply, placental health, including placental growth hormone secretion. And of course, we have to acknowledge that pathologic disorders such as genetic and chromosomal abnormalities, those factors or those quote unquote truths. It's notable that while growth hormone may not be the primary growth influence in utero, IGF-1 does remain critical. Okay, so I alluded earlier to various mechanisms for which influence growth in utero, and those likely have a direct influence on IGF-1, like maternal insulin. Okay, So for example, we see that there's several patients that have been described with growth hormone insensitivity that are caused by downstream mutations. For example, several patients have been described, or at least some, with STAT5B. And as we see here, here's a growth chart from one patient, and we can see both pre and postnatal growth failure. Okay. In this case, the patient had multiple infections, including pulmonary. And this also sort of demonstrates the ubiquitous nature of the STAT molecule, both in growth and in the immune system. So here we are back at our example from horse species. And so what does happen when we marry the large mare with the small stallion? Well, we're likely to have a large baby and see canalization. It's also known as channeling over the first 2 years to the genetic target. And of course, the opposite. Now, I'm not sure we need another example, but when I saw the engagement of Simone Biles this weekend to her boyfriend, who is a Texas football player named Jonathan Owens. I don't know if everyone is as enthralled with Simone Biles as I am, but she is 4'8" and he's 5'11". And it really made me think of this example and what I would expect if they do someday decide to have a baby. And based on maternal size of 4'8", I expect it to be somewhere down there. And then, of course, canalization too. Not that it's my business to guess what their plans are for the future, but they're celebrities. Okay, so serial measurements are an important parameter in monitoring the health of children. Okay, this has been emphasized throughout the day. A normal pattern of growth suggests good health, while growth that is slower than normal raises the possibility of an underlying subacute or chronic illness, including endocrine, systemic problems, underlying karyotype, or genetic disorders. Okay. Statural growth is continuous, but it's not linear. That's like something we say over and over again. It's continuous, but it's not linear. There are phases of postnatal growth. Okay, and that's what I'm going to focus on now. There's the infantile, childhood, and pubertal, and they each have a distinctive pattern. And these phases are same or similar, I should say, although perhaps shifted in males and female children. Okay, and particularly in puberty, it would be a little bit shifted even more, exaggeratingly. So as mentioned, Slice's birth is determined more by maternal nutrition, and intrauterine and placental factors than genetic. Not all the genes that affect growth may be expressed at birth. As a result, the correlation coefficient between birth length and adult height is only 0.25. During the first 2 years of life, the infantile phase, linear growth is usually very rapid and then gradually decelerates. Over this time period, you may see growth up to 30 to 35 centimeters. So as I pointed out a moment ago, an infant's height curve often crosses percentile lines during the first 24 hours of life, as growth moves away from the influence of the intrauterine environment and towards the child's genetic potential. The childhood phase is characterized by linear growth at a relatively constant velocity, with somewhat slowing in the later childhood. The pubertal phase is characterized by a growth spurt between 8 to 14 centimeters per year, due, as we talked about earlier, the synergistic effects of increasing gonadal steroids on growth hormone itself. In girls or females, the pubertal growth spurt typically starts around age of 10, but may be earlier. And in boys, typically 12, but of course, we know there's quite a bit of variability when it comes to puberty. So the major determinants now of postnatal growth include normal skeletal responsiveness, systemic health and nutrition, good nutritional balance, endocrinologic normalcy, and perhaps the greatest influence is what we biologically inherit, okay, our genetics. So here is an amazing picture of two great athletes. I already introduced you to Simone Biles, if you didn't know her, the greatest gymnast probably of all time. And the other is Shaquille O'Neal, who's known to be one of the greatest basketball players of all time. And I just love this picture of them together because they're really examples of people who have used their stature to their advantage in conjunction with, obviously, their enormous and very unusual talents. So now let's pivot to discussing how we can incorporate growth data as an integral measure of integrated health in childhood. Now, the good news is that the initial evaluation is actually quite simple, straightforward, and very repetitive. And most importantly, it will lead you to know when a child needs attention, either general attention or from a specialist, endocrinologist, or otherwise, even if the diagnosis isn't clear immediately, which is often not. And in fact, one of the cases I'll discuss had a delayed diagnosis. So our growth chart really is our best friend in evaluating these patients. We begin by describing our patient's height and weight relative to standards. And as Dr. Rappaport said, it depends on where you are in the world. Typically, we use World Health Organization and then CDC after 2 years of age. Okay. So we might consider height age and weight age. And what is that? Simply put, it's the age that correlates to, I'm going to just walk us through it, to the height and, it's the age that correlates to that weight or height if it were at the 50th percentile. And this information is just additive, right? It's all pieces of the puzzle. So for example, in this case, we can clearly see the child is falling off the growth curve, but the weight age perhaps would sway our attention in a different direction than the height because it is more severely affected. So next, we determine the genetic target based on the parent's height, and we can use that as a point of comparison. Growth evaluations, height and weight determinations remain the most useful of all indices. In public health, it tells us about their economic well-being. It tells us about quite a bit, particularly in countries, are undergoing transition. Determining growth velocity is absolutely critically, okay? If you can get a whole year data, all the better, okay? Then you can look at how that correlates. Then you can see how that correlates with age-defined norms. And a rule of thumb that I think is helpful is that at any age, at any time, if someone's growing less than 4 centimeters per year, it should raise alarms. Of course, that's just a sweeping statement. So it's very critical as well to throw in maturational status of our patient. Okay, and that includes a physical examination of puberty and perhaps a bone x-ray, a bone age x-ray if that's indicated. Okay, and with the bone age information as well as the coincident height of our patient, we can determine a predicted height and then go ahead and compare that to the genetic target. Now, please pardon me for any oversimplification, but the bottom line for the evaluation of children suspected of having short stature relevant to all ages can be thought of as guided by 3 simple questions. How short is the child? Is the child's growth velocity impaired? And what is their predicted height and how does that compare to their genetic target? The answers to these questions are going to guide a focus history and physical examination and in many cases, laboratory evaluations. We're endocrinologists, we love our labs. And this will most likely lead us to our answer, or at least to the right direction, which will ultimately lead us to our answer. And ultimately, the question is this pathologic or is this a normal variant? So at this point, I'd like to discuss sort of tidbits of different patient scenarios and offer some points of education, or as I said, pearls, as we go along this journey together. So, and this actually picture was put up by my colleague. And the reason, I'm going to take it away for a moment and then we'll put it back up. But the majority of our patients we're likely to encounter who have short stature, particularly of the mild variety, are not going to have pathologic underpinnings. That's the majority. But in many cases, they may have some significant distress. So regardless of our diagnoses or our treatment decision, it's really, really important to remain supportive and non-judgmental. And as Dr. Bargman said, we really have a deep-seated history of harm from society taking, and exploiting individuals with short stature. And she talked about Charles Sherwin Stratton, who was essentially sold to P.T. Barnum. In The Wizard of Oz, which I hate to say is actually one of my favorite movies of all time, but I always get a little angry or angry, maybe not so little, because the Munchkins, who actually have some of the most captivating scenes, if you look at the credits, are not credited by name. They're credited as a group, the Munchkins, not as individual human beings. And it's true, we have much better representation these days with surgeons who are advocates for little people and, world-class actors who are recognized all levels. But we still have this sort of humor and tradition of mockery. And that really does continue to ingrain a bias, whether it's overt or whether it's a hidden bias of some sort. Okay, so with that, what is the goal ultimately of evaluating our patients with short stature? To identify the subset of children with pathologic causes, such as Turner syndrome, that was discussed earlier today, inflammatory bowel disorders, or underlying systemic disease, or hormone deficiencies or excesses. The evaluation also assesses the severity of the short stature and likely growth trajectory, which facilitates decisions about interventions if appropriate. And Dr. Bargman discussed that at length today, and I will not be repetitious in that way. So I was taught a long time ago that once I answer the question about whether a child is indeed short, whether velocity is increased or growth is different than genetically expected, then I can start to consider the differential diagnosis in the following way. To consider primary causes, i.e. intrinsic to the ability of the child to grow, endocrine deficiencies or excesses, and then systemic problems or nutritional disorders. Now, diagnostic approaches may differ, but this approach is quite inclusive and allows our differential diagnosis and evaluation, I believe, to roll out quite naturally. So primary disorders of growth are disorders, as I said, intrinsic to growing in the skeleton itself. And they include familial short stature and idiopathic short stature and constitutional delay of growth and maturation most commonly. That's probably the number one thing that group of diagnoses we'll see for short stature. It includes chromosomal defects and karyotype defects such as Turner syndrome and skeletal dysplasias. And so that really starts us off, right? So we always are going to begin with a careful physical examination, really just back to the basics. And that really begins with our growth measurements. Okay, once we go beyond the initial height, we're going to look for any kind of disproportion. Okay, are the limbs disproportionately shorter than the trunk or vice versa? And that's going to start our differential diagnosis from that very first encounter. If proportions are normal, we're very likely discussing conditions such as ISS and systemic disease or endocrine disease. And if not, then we start to think about the primary skeletal dysplasias. And there are many, and they may be in the long bones or the axial skeletons. Skeleton. And from there, we can characterize it as proximal or distal, okay? We can measure the arm span, compare it to the height, right? It should be about equal, give or take 5 centimeters. We can do upper to lower body measurements. This also helps us assess disproportion, which we have to acknowledge is relative to age, okay? We can do a sitting height. So all of this contributes. Now, do we do it on every single patient coming in? Probably not, but somebody with short stature, particularly if there's an impression of some kind of dysmorphism, it's quite appropriate, it's inexpensive, and it's relatively easy. Okay, there are growth standards for almost everything. So what is the hallmark of skeletal dysplasias? The hallmark, as I said, really is disproportionate short stature. So these disorders result from mutations of genes whose products are required for normal skeletal maturation. Okay, in most cases, they are involved in endochondral ossification, which is the process by which the skeleton grows through the production of cartilage template and is converted into bone. The mutated genes encode cartilage and bone extracellular matrix protein, growth factors, growth factor receptors, intracellular signaling molecules, and transcription factors, and other molecules whose function are required for growth. And so here is an example. She's a para-Olympian named Eleanor Simmons, who has achondroplasia. And achondroplasia is the most common dysplasia in bone, and it's come up several times today. It is prevalent in about 1 in 20,000 live births. It's an autosomal dominant condition, and it's caused by pathogenic variations in fibroblast growth factor receptor 3. The most salient clinical features include disproportionate short stature, okay, long bone shortening with predominantly affecting the proximal aspects, which is called rhizomelia, and macrocephaly. Okay, macrocephaly is important to know because there are achondroplasia specific charts. And if one was charting on a typical chart, that patient may have unnecessary imaging or concern about something growing in the brain. Thanatophoric dysplasia is when there are 2 genes that are inherited. Hypochondroplasia is a more mild skeletal dysplasia. So here I am going to tell you about a boy that I met several years ago. At that time, he was 12 years of age, and he had a known diagnosis of achondroplasia, and he presented for growth amelioration. He really wanted growth hormone, and he was already in puberty. He did have a history of recurrent otitis media, which is not altogether uncommon. In fact, it's common among these patients. And he had a history of obstructive sleep apnea, also a characteristic problem. He had immigrated from Egypt at 10 years of age with his family. On physical exam, indeed, he had macrocephaly, frontal bossing, mid-facial retrusion, disproportionate short stature with rhizomelic shortening of the arms and the legs, brachydactyly, kyphoscoliosis, and accentuated lumbar lordosis, varus deformities. He was in mid-puberty, early to mid. He was intelligent. He was a very well-adjusted boy. Okay, so here he is. He would like growth hormone. And he was initially plotted on the wrong chart. And so we corrected that and looked at him differently. On the achondroplasia chart, he was growing, at least, I can't speak to the velocity. At the moment that I saw him, he was at the 50th percentile, and he was living with obesity. Okay. And so the question becomes, was growth hormone appropriate for this child? And when you think about, what is the problem here? So what would that correct? Would it correct a deficit? Would it correct an insensitivity? Or would it simply make its way over molecularly to the bone that was not behaving properly and would not change with that therapy? So from a molecular perspective, thinking back to mechanisms, it didn't make a whole lot of sense. And frankly, the use of growth hormone is not recommended in these cases. And although there have been some small trials, and it's thought that it can potentially worsen the disproportions. In fact, there has been some perhaps mild increase, but no long-term benefit. And so it's really not what has been touted at this juncture. Okay, so here I am, though, with this boy who's deeply distressed. And at that time, there was not that much else to offer. There were people discussing, so I'm going to go back. There were people discussing leg lengthening, which has been a surgical method that has been used, not commonly, very controversial, causes a lot of pain. It wasn't something that I was looking to push, although they did have a lot of questions about it. But as we heard earlier, my patient didn't get to benefit, but therapeutics have changed. Okay. And indeed, another therapy does exist and has been approved by the FDA about 4 months ago. I believe it was November 2021, that takes advantage of known FGF, FGFR3 molecular biology. And so how does this work? Okay, so we're going to have FGF stimulating FGFR3, and that causes it to homodimerize. Okay. And then this stimulates a downstream pathway that we know causes or inhibits chondrocyte differentiation and proliferation. Okay. So one can see, of course, just based on the normal physiology, if you have a constitutively active mutation, which is what happens with achondroplasia and this constant inhibition, then the growth is stunted and abnormal. Okay, so how can we interfere with this potentially? Okay, so the molecular story thickens. We talked about CNP, okay, and we know what it does is it has its own receptor, okay, NPRB, and through that, it's going to stimulate a whole downstream pathway, which actually inhibits the FGFR3 pathway. And so that's where this new medicine comes in, which is called vosoritide. Okay, and it works by binding to this natriuretic peptide receptor type B, NPRB, and stimulates the system, reducing the activity of FGFR3. In European Union, this is used at this point down to 2 years of age, and I believe it is approved for 5 years and above, as long as epiphyses are open or the growth plates are open. This was the result of a large, I think there was about 120 participants, international study, which was a placebo-controlled double-blind study that did show some improvement in height growth over a year of time without any change in body proportions, or at least not worsening of the body disproportions. Okay, so I'm going to move on to another case and just give you a few tidbits. Of course, not all the details. Okay, so here is a girl, and she comes to your office. She's 10 years of age, and she has gained weight and feeling really down about it. Okay, now I think so far, many of us would acknowledge that this is not sounding very unusual. And we even maybe wonder what it's doing in a short stature lecture. And so what do we think about this chart? What information do we really need? Because so far, there's nothing really that stands out, at least not to me. We want data, okay? And now, what do we see? We see there's been growth, velocity, depression, or poor growth over the last probably 2 years. And so never be reassured by normal data. You need growth velocity, okay? Particularly in light of increased overweight, one would not expect decreased growth velocity. So this child was counseled. Okay, this is a child I knew about, was not my patient, many years ago. She was counseled on nutritional changes, on diet, on lifestyle modifications. And this is what happened. She successfully lost weight. But what happened to her growth? Did she shrink? Can a child shrink? Okay, so what do we all do when this happens? We bring her back to the stadiometer and we measure her again and again. And let's say we get the same thing again. Well, we wonder if the last one was correct. That's the first thing that would go through my mind. But let's assume you were the one who did it. Now you're believing it. So thinking back,
there was a question about whether there's puberty.
Okay, good question. The truth is I'm going to make up an answer because I don't remember. What I'm going to say is there was acne and there was adrenarche, but there was not breast development. And that's a great question. And I think that the person who asked that question, and I apologize, I can't refer to you by name because I can't see the chat myself, knows what the answer is. And it was cortisol overproduction. So this was a case of pituitary macroadenoma. And what this young person had, in fact, was a osteoporotic fracture. And so the shrinking was indeed real. And so we have somebody who then ultimately had surgery and radiation treatment, and she did to some degree improve, but it was incomplete. And so what is catch-up growth? Okay, so this is characterized by height velocity above the limits of normal for age for at least 1 year after a transient period of growth inhibition. It can be complete or incomplete. And although the precise mechanisms remain elusive, it appears to be very well regulated. Okay, so now I'm going to tell you about cases that I met when I was a very junior attending, who I've seen for many years. Okay, so I'm going to begin with this 8-year-old girl with short stature. She came to me, she was prepubertal. Her weight at birth was small, but not extremely, we're told. She had immigrated from Yemen 2 weeks prior. She was living with an aunt and the paternal uncle, okay, even though she presented with her father. And this was very interesting. And I don't usually comment on insurance or how people pay. Frankly, I probably don't pay enough attention to that aspect of medicine. But this was someone who walked into my clinic someone came up to me and said, can you see them? They're really upset and they're willing just to pay out of pocket. Not a wealthy family, by the way. And why I'm mentioning that is because it spoke to the urgency, the desperation of this family who had basically saved everything they could just to bring their child, who they really worried there was something wrong with, to a place where they felt they can get good care. Okay. She appeared younger than stated age. She had a very high-pitched voice. She had very soft abdominal musculature. I always remember she was very thin, but it was like she had such little muscle mass. She had normal skeletal proportions, no Maternal deformity, Tanner 1 breast and pubic hair. And I mentioned Maternal deformity because that's something That is one of the features that we describe with Turner syndrome and with a young girl. It's always on my mind. And so what is it? It's basically a deformity of the wrist, which is caused by growth disturbance in the inferior volar part of the epiphyseal growth plate, and results in the distal radius, which is displaced in a volar direction. Okay, so here we have our 8 and change-year-old girl who's very short and has a very delayed bone age. And her weight age is even smaller than her height age. Okay, so now I'm getting to know this family a little bit better. And here's our child. He is somebody who has 2 wives, and the wife who is the mother of this child is his first cousin. Okay, he and she are both short-statured people, but not to the same extreme as their daughter. He describes, I didn't meet at this time, an older child, a full sibling, who is also shorter than peers, but nothing extreme. And he said his younger son is even relatively smaller. He's a year behind this child, even relatively smaller than she is. And I'll tell you about him later and why he wasn't at that visit, which is very fascinating. So what do we do? Okay, I'm thinking about all of this, these categories. So this is the type of evaluation that I'm going to conduct based on these considerations, probably not very unusual. And what do I know? I'm going to cut to the chase. I know that she had a normal karyotypic composition and a normal Shox gene. I know that her IGF-1 was very low. And I know that she has celiac. I also know that she had slightly depressed cell lines in her complete blood count across the board. There are a few things, right? We don't like that in pediatrics, right? We like Occam's razor. We like there to be one thing that ties us together. And so, the question, and she did have an endoscopy that showed celiac. And so our question was, is that the whole picture? We know that when you have malnutrition, that does confer some growth hormone insensitivity, and that IGF-1 may be poorly produced. But is that the whole picture? We didn't think so. And so imaging was done, and this showed pituitary underdevelopment. Okay, so here we are. What do I know? I know that she has growth deficiency due to a primary pituitary defect, and she also has celiac. Okay, so we started growth hormone and a gluten-free diet. And this is what ensued. So she started to grow quite well, as one would expect, but her weight didn't quite follow the same curve. And so we're left wondering, what is that? And also, what about that CBC? Now, the CBC did not improve, and we conferred with our hemonc colleagues, and it showed a hypocellular marrow with aplastic anemia. Okay.
There was a question whether there was growth hormone stimulation done.
No, we did not, because she had an abnormal pituitary and very low IGF-1. And so we didn't think it had any diagnostic additive effects. Good question. And Dr. Chin, I do see that time is short and I have a few more cases. So I'm going to get through this boy and then jump to the end. Okay. So just so you know my plan, and another day we'll come back and talk about all the other really interesting cases. So while we were thinking about this, the boy arrived. Okay. And we got to meet him. And we learned at that time he was a year behind his sister. He was just above 8, and he literally just came from Yemen. Okay, and why didn't he bring him? He was more concerned about his son than his daughter because he seemed much more extreme, which I'll show you he was right. Why? Because the passport control said, this boy is not 8 years old. And they showed the passport. Yes, it is. No, can't be. He looks like a baby. They said, okay, what did they tell them to go get? A bone age. Was that helpful? Not at all, because his bone age certainly was not going to be congruent with his age. So the father had to go through all kinds of hoops and, you know, and such to be able to prove that this was indeed his child. And this is when we first met him. Okay. His height age was 2.5. His weight age was under 2. And in fact, I remember that my youngest daughter or child was a year at the time. And at that time, my child, they weighed more than this 9-year-old. Okay. So I think we all would characterize this as a very severe picture, almost 8 standard deviations below the mean. So what did I do from here? A very similar evaluation. IGF-1, of course, as you suspected, was undetectable. The rest was normal, other than also mildly mildly suppressed cell lines as well. Imaging showed a severely hypoplastic pituitary gland. Now, I glossed over this detail before, but importantly, he had a duplicate thumb. Does that ring any bells to anybody? Pardon me.
Somebody wrote in the chat, Fanconi's anemia.
Okay, brilliant. So I'm going to complete the story for you because we still have an important question, an important dilemma. So here he is, and he has now this thumb anomaly and bone marrow suppression, as does his sister, both products of a consanguineous relationship. And so we finally wised up and asked the same question that you just asked: is it possible that this person has Fanconi anemia? For those who aren't quite as clever, this is a rare genetic disease resulting in impaired response to DNA damage. And so basically the normal repair, you know, we always have damage going on, whether it's in our embryologic formation or, you know, in our bodies going forward. And we're constantly repairing it so that we're not embryologically, you know, have defects or develop cancer. And the problem in Fanconi's anemia is in several genes. I think there's more than 14 at last check that they cannot repair well this DNA damage. And so the way you test it is to apply diapoxybutane, and they look at how the DNA repairs with this toxin. And both the siblings did indeed have this condition. The older sibling, who I then met at around that same time, did not. And he had what we considered familial short stature. Now, I just want to show you that this younger half sibling was not my patient, but I did meet him, and I'm going to just show you. This was he at 5 years old versus his brother at 9, who had already grown. And just to bring us back to the question, do you treat, right? So these patients have severe growth hormone deficiency. That young man could not reach the doorknob, okay? His function would have been so impaired. The family was desperate, absolutely desperate. And this was a very big decision. Here I was, maybe a year or two out of fellowship. I don't even think that long. And I did not know if it was the right thing to do. And for those who don't know, these patients are incredibly likely, more than 90% will have some kind of cancer relatively early in life, including blood cancers, most commonly 50% even solid tumors. So to give somebody a growth stimulant who is so likely to have a malignancy to begin with is a real dilemma. Okay, real dilemma, and something I took very seriously. Ultimately, I conferred with experts at on Long Island and then in the city at Sloan Kettering, and we did treat modestly. And this is the boy. Okay, so you can see he's still about -3 standard deviations, but different than -8. And here is my young lady now, who again is about -3 standard deviations, different than -5.5. Perfect? No, they both had bone marrow transplantations at this point, and they are no longer on growth hormone. And because the hour is late, I am unfortunately not going to, I'm going to just bring you to my summary. And you bear with me. I did have such interesting cases, but another time, another place. That's how I get invited back. Hopefully. Okay. In summary, it's all simple in the end, right? When we have a patient who we're concerned about short stature, our main goal is to identify the subset who have a pathologic cause. Not to say we don't treat those who have benign causes for short stature, but what we really need to do first is make sure we find those who have a problem that we need to help them with, okay? We do this by finding out, are they short? Let's measure them. Let's measure them ourselves. Let's measure them in every way we can think of that might be relevant. What is their growth velocity? What is their predicted adult height? How does that differ from their genetic potential? Then we put them into baskets. We start to think about the differential diagnoses, and our evaluation will roll out from thinking, is this a primary disorder? Is this endocrine? Is this systemic? And you may not come up with the answer right away, but you will, and you'll know the right questions to ask. Thank you so much for your time and for your chats and for your questions. They were wonderful.
Thank you so much, Dr. Jacobson. Any questions?
Sorry, can we go back to case number 2? I'm kind of wondering, what was there was a tumor, like something with the pituitary. I didn't get it. I didn't get enough time.
So she had Cushing's. She had Cushing's.
Oh, okay.
I'm so sorry that I
that's fine.
went too
Thank you.
quickly. That she had Cushing's. So she had an ACTH dependent cortisol excess, which is not common in
That's very
children.
rare, right?
Yes, in children.
Thank you.
My pleasure indeed. Thank you for your question.
So if there are no other questions, I'd like to thank everybody for participating, and thank you to all the speakers. Can we keep ourselves on mute just until we finish? Sorry. So thank you to all the speakers. The recording of this meeting will be available to you after the meeting. If you have any issues with connectivity, you can see the meeting later. In your email, you'll receive a link to evaluate this meeting, as well as to apply for CME credits. So your feedback is very important to us. Please take a moment to evaluate it. There's also a link in the chat. And I wanted to lastly thank Asia Miller, the fellow who helped apply for the grant. We received unrestricted education grant from Pfizer for their support for this meeting that is providing us with free CME credits. So thank you very much, everyone. And that's it.
Thank you so much to the organizers.
Yep, you're welcome. I'll leave this slide up just for a few moments for people to copy, but thank you.